Good afternoon and welcome to day 2 of the Mayor's Health Equity Summit. Today we will be talking about mental health and preventing community and youth violence. So today we have Dr. Bev Frida Jackson here to speak to us about mental health. Bev has over 15 years of experience in the area of civil rights and social justice education, with a specialized focus to examine issues of social justice through deconstructing and identifying racial disparities and disproportionately in voting, racial isolation, segregation in the public education system, and identification of systematic disparate treatment of communities of color. We have Dr. Jackson here to highlight behavioral health, as we have declared racism as a public health issue. And so she's going to really talk about how racism plays a integral part in behavioral health in the African-American community. Dr. Bev Frida Jackson, thank you for joining us, and I'm going to turn the floor over to you.
Excellent. Thank you so much, Tamika. It is an absolute pleasure to be with you this afternoon to talk about the public health framework that we utilize in many ways. I'm going to actually go ahead and begin to share my presentation. So there we go. So as Tamika shared, I want to talk with you this afternoon about mental health, but then also too, how we also expand our framework, we expand our discussion. So I seek for us to expand our examination of equity to utilize a public health framework to truly include mental, physical, and behavioral priorities. And so as we begin, I think definitions are extremely important. So beginning with health equity. Now, health equity is defined as the principle underlying the commitment, to reduce and to ultimately eliminate disparities in health and its determinants, including those of the social determinant orientation. Now, what I will talk about later on in this presentation is we'll talk about what are those social determinants of health. Health equity, it means truly striving for the highest possible standard of health. And we're talking across the continuum. So we're talking across for multiple persons. Additionally, when we're talking about the intention around health equity, we're seeking to give special attention to the needs of those at greatest risk of poor health based on social conditions. So that's our first definition. Our next definition is around health disparity. Now, health disparity is the metric that we so use to measure progress toward achieving health equity. Now, when we seek to reduce disparity, that's evidence that we're moving trajectory-wise in the direction that we so seek in terms of moving towards greater equity. Now, this can look very, very different. Ideally, we're talking about economically and socially ensuring that platforms and playing fields are leveled. Interestingly enough, when we talk about health equity means that there's a fair and just opportunity. It requires removing obstacles such as poverty, discrimination, and the consequences of what we like to determine as powerlessness and a lack of access to quote unquote good jobs, to fair pay, to education, housing, safe environments, and healthcare. Now, when we pivot a little bit and we talk about that disparity component, the objective is to refer to differences specifically in disease burden, right? So we're talking about disparity versus equity. Disparities are patterns that we might observe that are related to specific outcomes. So perhaps a higher burden of illness or disability or mortality. We talked about mortality in day 1 of our conversation here at the Equity Summit. Mortality experienced by a certain group for a specific reason. Traditionally, when we talk about the macro umbrella of healthcare disparity, we're talking about groups that maybe we're talking about healthcare insurance coverage and or access to services. We'll cover that full continuum because what I share with you this afternoon is the opportunity to expand how we talk about equity through the multiple lenses: mental health, physical health, behavioral health, but then also from a diunital reasoning approach. The next definition I want to bring to the fore is around behavioral health equity. Now, this is the right to access quality health care for all populations, regardless of the individual's race, ethnicity, gender, socioeconomic status, sexual orientation, or even geographic location. Now, when we're talking about behavioral health equity, we're also talking about mechanisms of prevention. We're talking about treatment, and we're also talking about recovery services for mental and substance abuse disorders. So oftentimes we'll find that mental health and behavioral health will be used interchangeably. And so what I wanted to bring to the fore today is a distinction, because language is so powerful. And so to ensure that we are on the same page in terms of our understanding of mental health and behavioral health, I want to posit that mental health truly covers many of the same issues of behavioral health, but the term only encompasses the biological component of this aspect of wellness. And so I'll reiterate that mental health covers many of the same issues as behavioral health, but the term primarily encompasses the biological component of this aspect of wellness. So therefore, the term behavioral health truly encompasses all of the contributions to mental health wellness. So we're talking about behaviors, we're talking about habits, we're talking about external forces. And so behavioral health equity is how we fold in the formula of quality services. So behavioral health equity involves addressing social determinants, employment, housing, stability, insurance status, proximity to services, culturally responsive care. I'll close out the discussion with you this afternoon about what does culturally responsive care look like. All of this has impact on behavioral health outcomes. So the framework that's posited, the framework for consideration is how do we examine a health equity framework that's more expansive in scope, where it's less siloed, it's more diunital in reasoning. Firstly, we need to look at how do we improve the quality of care. Secondly, we want to consider what does it mean to increase access to care? And what does that look like across communities? Service arrays can be extremely expansive. However, with an expansive service array, but without persons being able to access those services and looking at utilization that's low, that's something for us to truly think about. Estimating the economic burden and the financial cost of disparities. When we do an impact analysis, when we do a cost-benefit analysis, what does that truly look like across communities? I'm going to provide some empirical supports on this presentation that speaks to why the need, where the need is. When we look at the economic burden and the financial cost of disparity, what does that dollar sign, what does that look like? Next, we want to evaluate the effects of the healthcare delivery system. Disparity exists in multiple forms. There's disparity, coverage disparity, there's treatment disparity. I'll talk about that in this discussion, and then we have our panel discussion later where we'll delve even more into, more specifically, a mental health dialogue and what treatment and diagnosis and service disparity truly looks like there. But how do we truly evaluate the effectiveness of the healthcare delivery system? What are the gaps? What's working as well? You know, we want to infuse a strength-based model, knowing that there's some deficits, but with the ultimate objective of an evaluation system that helps to improve outcomes. Next, let's look at reviewing payment models. We are well aware when we talk about services, when we talk about treatment potentially, that persons are priced out. So what are payment models looking like in terms of supporting equity as it relates to health, treatment, diagnosis, and services? Let's explore disparity and disease across communities. When looking at the physical health domain, I'll share some data with you, specifically looking at communities of color, looking at the African American community, and looking at the data as it relates to diabetes, heart disease, chronic liver disease. You know, very impactful data out of the Office of Minority Health that helps us better understand and gives us a face, an empirical face, as to disparity and disease across communities. Additionally, when we re-examine this framework, when we expand this framework, how do we strengthen the population, health, and community root cause analysis? So once we identify, we've got indicators to help give us a sense as to what the challenges may look like as it relates to health disparity. And that, of course, being the metric that moves us towards that ultimate objective of health equity. What's the root cause analysis? Where is this coming from? How do we better understand the source? Because once we better understand the source, it can help us truly come up with some solutions. So furthering this conversation around the need the need for the expansive conversation, the need for adjusting the framework, I want to step through some data for you. So the data in mind, in 2019, nearly 56% of non-Hispanic Blacks, in comparison to others, used private health insurance. Now, when we look at 2019 data again, 43.5% of non-Hispanic Blacks in comparison to 34.3% of non-Hispanic whites relied on Medicaid or public health insurance. Part of bringing this conversation to the fore is to say, okay, exactly from the empirical landscape, where are the gaps, where are the needs? Especially when we talk about coverage. If there's in fact, we have variance in terms of disease treatment and diagnosis, coverage rises to the top. 10.1% of non-Hispanic Blacks in comparison to 6.3% of non-Hispanic whites were uninsured. Now, when we evolve and look even more at life expectancy and also some physical indicators of health, according to the Census Bureau projections, the 2020 life expectations at birth for Blacks, 77 years, 79.8 years for women, 74 years for men. Non-Hispanic whites, the projected life is 81 years, 83 years for women, and 78 years for men. Now, if we look at the death rate, Blacks, it's generally higher than whites, and it's across domains. We're talking about heart disease, stroke, cancer, asthma, the flu, pneumonia, diabetes, HIV, AIDS, and homicide. So the need for examination expansion, the empirical landscape, this is the table setting piece. This is the table setting opportunity for us to really think about the why the need for a discussion around how we reframe, not to just look linearly at the physical piece or behavioral or mental health, but all of those pieces together. That's what I posit for you as for us is to infuse or consider a diunital reasoning model. Now, a diunital reasoning model, it allows you to see things in a full mechanism, full way. At the same time, we've got behavioral health, physical health, and mental health. Now, truly all are independent, correct? But while they're all independent, they all are full within their own right as well. So what a diunital reasoning model allows for is the infusion of a multidimensional reality in terms of how we approach equity. And thereby, it forces the hand around an expansive lens around health equity. So how do we tackle this? We tackle this from a multidimensional scope, utilizing not a traditional way. Our traditional way to examine health has been dichotomous. It's either this or it's either that. Is it behavioral health, or maybe it's physical health, or maybe it's mental health? Perhaps, though, it's a confluence, right? The diunital reasoning allows for that independence, but equality at the same time, while infusing that multidimensional aspect at the same time as well. So mental health, when we talk about our lenses and we talk about mental health, equity is in fact health equity. We're talking about some of the same need, the same barriers. Some of the data that I want to begin sharing with you as well. The next few slides are dedicated to looking at the empirical drivers around mental and behavioral health. Again, the distinction between the two being that mental health covers many of the same issues of behavioral health, but the term only encompasses the biological component. So therefore, I want to infuse into our vernacular the behavioral health component that's encompassing contributions to wellness, the contributions to mental health wellness that include abuse, behavior, habits, and other external forces. So beginning with our first data point, in 2019, suicide was the second leading cause of death for Blacks, or at ages 15 to 24. The death rate from suicide for African-American men was 4 times greater than that of African-American women. The picture that I'm seeking to paint for you with the data is the need for treatment, but also a need relative to correct diagnosis. And our panel discussion that will follow this keynote address will delve into some of the challenges around treatment, challenges around diagnosis, and the outcomes therein. So the overall suicide rate for African Americans was 60% lower than that of non-Hispanic white population. Black females, young women, grades 9 to 12, were 60% more likely to attempt suicide in 2019. That's compared to their counterparts. 60% is extremely high. Now, when we fold in factors such as poverty, we know that poverty definitely impacts and affects mental health. So when you fold in that particular variable, we recognize that African Americans are living below the poverty line, as compared to counterparts. And so therefore, the reality of serious psychological distress is something for us to keep in mind. It is a reality in very real ways. A report from the Surgeon General that looks at an expansive window of 1980 to 1995 just looked at the suicide rate, ages 10 to 14. That increased by 233% as compared to 120% of non-Hispanic whites. Again, I'll reiterate, ages 10 to 14. We'll talk about what's happening within our communities. 233% is hugely exponential in terms of that increase. Now, 13.4% of the US population identifies as African American. Now, that's over 7 million people when we look at, of all of those, 16% reported have a mental illness in the past year. That's over 7 million people. To give us a sense as to the numbers, what are we, how do we apply that? More people than the populations of Chicago, Houston, and Philadelphia combined. We're talking about substantial numbers. Again, reinforcing the empirical drivers that reinforce the reality of the needs that we have. Delving into the data some more. Serious psychological distress in the past year. And the data that we're looking at is data that is the 2019 window. We're looking at among adults of 18 years of age and older. Non-Hispanic Blacks, roughly 11.9%. Non-Hispanic whites at 12.7%, and non-Hispanic Black to white ratio 0.9. So we see some variance here, not a huge amount in terms of statistical difference, but we still are speaking to a need across the community. Now, the percentage of the population with serious psychological distress of persons 18 years or older in 2018, disaggregating this by men and women, looking at non-Hispanic Black, non-Hispanic white, non-Hispanic Black and white as well, we'll see some variance with men at 2.5, women at 4.7, and a total of 3.7 when we're specifically looking at non-Hispanic Blacks. Now, non-Hispanic whites, we see percentage or ratios of 2.8, 4.8, and 3.8. Again, not a huge variance between the two subpopulations, but again, the objective is to reinforce the need that's living within the community as we discuss this. Additional data shares that the percentage of population with feelings of sadness, hopelessness, worthlessness, or something, or that everything is an effort, that everything is perhaps challenging. This is a key variable when we look at behavioral health, because again, the behavioral health component is looking at how do these feelings manifest in terms of your reality. And so when we look specifically though for the non-Hispanic Black population, we do see some variance compared to the other data points shared previously. For sadness, we're at 4.2, hopelessness at 1.8, worthlessness at 1.8. Everything is an effort as 11. Which is definitely on the higher side compared to 2.6, 2.2, 2.3, and 6.6 for non-Hispanic whites, and the variance of 1.6, 0.8, 0.7, and 1.7 for non-Hispanic Blacks and non-Hispanic white ratio. So the reality that everything is an effort highly correlates with our prior slide that speaks of when living below the poverty level, how that impacts one's mental health. Now, if we look at the percentage of population with serious psychological distress of persons 18 years or older from 2018, slightly different data point, just a year prior than 2019 data. We see 2.5, 4.7, 2.8, 4.8, 3.8. Again, when we look at serious psychological distress, and I'll talk through some of the diagnoses such as schizophrenia, mood disorders, and the like that will be applied to the community, to communities of color. It disaggregates once more and it details once more the need for proper diagnosis and proper treatment based upon the ratios that we see from the Office of Minority Health. Psychological distress is a reality that is very much impacting our communities of color. And also treatment and services. And I want to step back and do a little bit of table setting before hopping into some more data as this presentation continues to evolve. African Americans are more often diagnosed with schizophrenia and less often diagnosed with mood disorders compared to the white counterparts with the same symptoms. And we'll talk about this some more in the panel discussion that will be forthcoming. Additionally, when we look at medication and therapy, oftentimes African Americans are offered medication or therapy at lower rates than the general population. So if we pause for a second, we're talking about diagnosis that may or may not be correct. And then also medications offered and therapy offered at lower rates. Definitely speaking to challenges around equity in health, and especially along the continuum of race equity. Additionally, African Americans are overrepresented in our jails and prisons. African Americans make up about 13% of the general population. That's kind of reinforced from our prior slide, but nearly 40% of the population is in prison. So the reality is if we correlate mental health and what we see around corrections, we actually identify the fact that for the most part, the imprisonment rate for African American men is 6 times greater than for white men. And quite simply, there's oftentimes an involved psychosis that is a part of the equation. More often than not, there are African Americans in jail with mental health conditions that are not addressed in the way that they need to be addressed. Additionally, when we look at disparities across types and SAMHSA has been an excellent source for some of this empirical supports. 16% of African Americans report having a mental health illness. Another 22.4%, and this is 2018 data, report having a serious mental health illness over the past year, but 69% are like, I have not been treated. So you have upwards of 22%, another 16% that identify as having a mental health illness. However, you'll unfortunately have nearly 70% that are not receiving treatment services for mental health. Similarly, looking at data just a year prior in 2017, we recognize the fact that suicide and mental health, the correlation there, that there is empirical support along just general communities of color. So we've got our African American community that I've just highlighted for you, but the second leading cause of death among Native Americans and Alaska Natives ages 10 to 34 was suicide in 2017. Now in 2018, 14.1% of American Indian and Alaska Natives received mental health services, and an 18.6% received supports in our white community. As is evidenced by the data, we recognize that mental health is a critical need. Mental health is also manifesting itself in behavioral need, is a need of the community in terms of treatment and services. So pivoting now to services and looking at the landscape around services, the percentage of adults age 18 and over who received mental health services in the past year. If we look at the numbers, we see that non-Hispanic Blacks, it reinforces some of the SAMHSA data that I previously shared, that unfortunately we're looking at 9.8%, 19.8 for non-Hispanic whites and 0.5 for non-Hispanic Black, non-Hispanic whites in terms of ratio. But that 9.8 is blaring, considering the percentages the percentages and also the diagnoses conversation previously shared. The percentage of adults over 18 who received prescription medications for mental health services in 2019. Non-Hispanic Black was at 6.5. Non-Hispanic whites at 16.6. Again, I'll reiterate the statistic that traditionally African Americans are diagnosed with schizophrenia and less often diagnosed with mood disorders with the same symptoms. Oftentimes, African Americans are not offered medication or therapy. And oftentimes these lower rates are what we'll see. And so the data helps to support this. The percentage of adults age 18 and over with past year depressive episodes who received treatment, 59.6 for non-Hispanic Blacks, 70.2 for whites. So we're seeing a trend. We're seeing a consistent trend relative to treatment, consistent trend relative to whether that's therapy, whether that's medication, that communities of color are not receiving in the same way as white counterparts. And so this in and of itself speaks to that manifestation of health disparity, that metric that recognizes inequity in health. So treatment disparity. So disparities, they exist in multiple ways, right? I'm going to talk a little bit now about treatment disparity, and then we'll also talk about coverage disparity, because both are quite impactful when we talk about health equity. So disparities in access to care and treatment for African Americans have persisted for an extremely long time. Now, we had the implementation of the Affordable Care Act, and that helped to close the gap for uninsured individuals. But quite simply, 11.5% of African Americans versus 7.5% of white Americans are still uninsured, and that was 2018 data. Okay. Additionally, in 2018, 58.2% of African Americans, young adults, and we're talking that 18 to 25 continuum, 50.1% adults, 26 to 49 have serious mental illness, did not receive treatment. So the domains of disparity, treatment is a macro one. Nearly 90% of African Americans, when we're talking about children over the age of 12 with a substance abuse disorder, did not receive treatment. A recurring theme, a recurring trend is not receiving treatment across racial lines, as reinforced by the data that we just examined from the Office of Minority Health, reinforced with some additional statistics from SAMHSA. Now, reeling back our data just a tad, in 2016, roughly 12.3% of African American adults who had a doctor's office or clinic visit had difficulty getting care, tests, treatment, compared to 6.8% of white adults. Again, reinforcing the disparity that we're seeing within our system. We also have coverage disparity that is a reality as well. In 2019, coverage differed across race and Hispanic origin groups. The uninsured rates for non-Hispanic whites and Asians was 5.2% and 6.2% respectively. Now, the percentages for Blacks and Hispanics with no health insurance coverage for the whole year you had for non-Hispanic whites was 9.6% and 16.7% respectively for Hispanics, had the highest uninsured rate. So I've identified coverage and treatment as key areas for us to think about as it relates to health disparity. Now, it took some time to initially to set the table to have us talk about mental health and behavioral health. The next piece of that multi-pronged approach, or that diunital reasoning that I propose we consider in this conversation, is physical health. And so physical health data, I want to begin with the domain of asthma. So when looking at the data, in 2018, 2.7 million non-Hispanic Blacks reported they currently have asthma. Now, traditionally, when we talk about asthma, we look at the asthma conversation, that actually folds us into a larger dialogue about environmental injustice, which it is another portfolio conversation as to inequity that we see in communities. And something for us to just keep on the radar, to continue to think about. Non-Hispanic African Americans were 40% more likely to have asthma than non-Hispanic whites in 2018. Now, in 2019, non-Hispanic Blacks were almost 3 times more likely to die from asthma-related causes than non-Hispanic white populations. Now, when we think of asthma, again, I ask you to truly consider the role of environmental justice and environmental injustice when we look at communities and when we look at perhaps pollution, and also where communities are so located in terms of their air quality. In 2019, non-Hispanic Black children had a death rate 8 times that of non-Hispanic white children. Non-Hispanic Black children were 5 times more likely to be admitted to the hospital for asthma as compared to non-Hispanic white children. And then while all the causes of asthma, they're unclear, sometimes it's tobacco smoke, lower respiratory tract infections, children living below the poverty level, which is how we get to the conversation around environmental injustice. Children that live near the poverty level are more likely to have levels of blood constantine, a breakdown of nicotine, and children living in higher income families. And so thereby that folds the correlation conversation around environmental injustice and the communities, and ultimately the impact that we're having on African Americans. Now, shifting to a cancer conversation and data from the Office of Minority Health around, so what does disparity look like in the African American community specifically, and looking at physical health, but this time cancer. African Americans have the highest mortality rate of any racial and ethnic group for all cancers combined. Death rates for all major causes of death are higher for African Americans. And that's what impacts life expectancy. I'll talk about the social determinants of health moving forward. And among the metrics that we've identified with the social determinants of health is life expectancy. And so it becomes a natural part of the conversation to examine death rates and rationales as to what we're seeing. Roughly from 2014 to 2018, African-American men were 1.2 times and 1.5 times respectively more likely to have new cases of colon cancer and prostate cancer as compared to their white counterparts. Additionally, African-American men are 1.8 times as likely to have stomach cancer as compared to white men, which is at a 2.5 times more likely than to have stomach cancer. Now, African-American men have a slightly lower 5-year cancer survival rate for certain cancers, for certain cancer sites. Additionally, African-American men are twice as likely to die from prostate cancer. So as I'm sharing the statistics, the trends might not dissimilarly from some of what we heard, of course, with the mental and behavioral health data, we're seeing trends that are impacting the community, but also it's validated empirically at the same time. Now, African-American women are twice as likely to be diagnosed with stomach cancer and 2.2 times more likely to die from stomach cancer compared to non-Hispanic white women. And pivoting back to looking at breast cancer, between 2014 and 2018, African-American women are just as likely to have been diagnosed with breast cancer. However, the caveat is this: they were almost 40% more likely to die from breast cancer as compared to non-Hispanic white women. So again, we see the disparities, and our first domain was looking at asthma, so looking at air quality. Our next physical health domain was looking at cancer. And we're seeing recurring themes across a community of color, across the African-American community compared to white counterparts. Now looking at chronic liver disease and physical health. Chronic liver disease was the 8th leading cause of death for non-Hispanic Blacks between the ages of 45 and 64. And again, this data, we're looking at data points, roughly 2019 data points. African-American men are 60% more likely to have liver and IBD cancer and to die from this disease compared to their white counterparts. Additionally, African Americans generally, when we talk about chronic liver disease, it's a leading cause of death, period. Now, the challenge is while the cause is not necessarily known, and that gets us back to the root cause. In examining our framework and expanding our framework, one of the asks that I brought to the fore was around root cause analysis. So when we talk about chronic liver disease, while the cause is not always known, some cases can be initiated by conditions such as chronic alcoholism, obesity, and hepatitis, but doing more work around root cause analysis will help us get a better sense of how we shrink that metric of health disparity and move in that trajectory of health equity. The next domain that I want to talk us through is physical health and looking at diabetes. So in 2018, non-Hispanic Blacks were twice as likely as non-Hispanic whites to die from diabetes. Additionally, in 2017, non-Hispanic Blacks were 3.2 times more likely to be diagnosed with end-stage renal disease compared to their white counterparts. Now, African-American adults are 60% more likely than non-Hispanic white adults to be diagnosed, period, with diabetes by a physician. And now in 2017, non-Hispanic Blacks were 2.3 times more likely to be hospitalized for amputations compared to non-Hispanic whites, of course, being an amputee byproduct of diabetes. And the last domain that we'll look at relative to physical health to really provide the lens around disparity is heart disease. So heart disease in African Americans generally, in 2018, African Americans were 30% more likely to die from heart disease than non-Hispanic whites. Although African American adults are 40% more likely to have high blood pressure, they're less likely than non-Hispanic whites to have their blood pressure under control. So again, I reiterate, at the beginning of the treatment disparity conversation, I shared a data point with you about medications and lower rates of actual service. It's reinforced with this data. African American women are 60% more likely to have high blood pressure compared to non-Hispanic white women. Now, again, what gets infused into this discussion, and can't help to get infused into this discussion, is the environmental injustice conversation. Also, what are social determinants that are translating into why we're seeing some of the physical health disparities that I've identified for you in the data? So what we need to do once the data, empirical drivers are very impactful. Empirical drivers provide for us the opportunity to truly see, to get a face of the population, to see inequity, to get an idea as to where we need to go. From that lens, we see to move from health disparity to health equity. But the question is how? What does that look like? We talked about treatment and disparity as it relates to coverage. We talked about disparity as it relates to physical, mental, and behavioral health. With all of that in tow, how do we potentially address moving from health disparity to health equity? So among those is to examine the social determinants of health. A familiar place is Healthy People 2030. And so I will talk about Healthy People 2030 as I move forward in the presentation, but also firstly wanting to define the social determinants of health, because what we saw with some of the empirical drivers were definitely heavily rooted in these social determinants. So by definition, when we're talking about social determinants, we're talking about conditions in the environment where people are born, where they live, where they learn, work, play, worship. All of these are factors in terms of how we define quality of life outcomes, but it also speaks to risk. So if we think about social determinants of health, we can't help but infuse into the discussion the concepts of protective factors and risk factors as well. So there are key domains of our social determinants of health that are identified by the Department of Health. And I want to step through those, but then also kind of explicate a little more as to the goals that we're seeing with these particular domains. Because the social determinants of health themselves, they can have a major impact just generally on well-being and just quality of life. Because the objective of identifying these social determinants of health is to really have us think through key indicators. And among those key indicators that we want to think about what does safe housing look like in communities? What does transportation look like in communities? What do our neighborhoods look like? Another determinant or another other examples for us to think about around the social determinants of health. What is the impact of racism, the impact of discrimination, the impact of violence? Additionally, we want to infuse a lens that forces us to look at education, look at job opportunities, to look at income. We want to look at multiple variables when we introduce our social determinants of health. We also want to think about access to nutritious foods. What about food deserts? Foods, physical activity opportunities, polluted air and water. That's the environmental justice / environmental injustice conversation as well. So the first domain that I'll begin sharing with you is around economic stability. Now, economic stability, when we think of the social determinant of health, has some key drivers. You know, the goal is to help people earn steady incomes that allow them to meet their health needs. If we unpack that a little bit more and we think about the economic stability objectives, the key aim is to truly reduce the proportion of adolescents and young adults who aren't in school or working. So an objective of the social determinants of health macro is for us to identify goals, but goals that we can measure, that we can operationalize to see if we're getting true traction. So another metric of economic stability in terms of objectives is reducing the proportion of people living in poverty. Another objective is increasing employment in working age people. And then another objective is increasing the proportion of children living with at least one parent who works full time. So to give us a sense of kind of how economic stability works under the umbrella of the social determinants of health domains, employment programs, career counseling, high quality childcare opportunities, these are all factors that fold into making that goal a reality of helping persons earn steady income. Quite simply, when we think about the social determinant of health domain, specifically as it relates to economic stability, steady employment, if you have steady employment, you are less likely to live in poverty and also less likely, and you're also more likely to be healthy. But we'll often find that persons have a hard time finding or keeping a job. So when we superimpose that challenge with disabilities or injuries or conditions, health conditions, that's how the social determinant of health rises to the top. The next domain that I want to talk about is education access and quality. Now, the goal for education access and quality is to increase educational opportunities and help children and adolescents to do well in school. Now, unpacking that a little bit more as well, persons with higher levels of education are more likely to be healthier and to live longer. And there's, correlation, empirical correlation that seeks to support this particular statement. Healthy People 2030, and I'll kind of show a visual that speaks through the macro vision and mission of 2030 moving forward. But the 2030 Healthy People really seeks to focus on high quality educational opportunities for children and adolescents. That is a key driver. Children from low income families, children with disabilities, or perhaps children that routinely they might be impacted or routinely experiencing some form of social discrimination, perhaps bullying. They're going to struggle in math and reading. And they're also less likely to go to high school or to college. If you are not on grade level in third or eighth grade, the likelihood of you touching a system, some system, and more often than not, the juvenile justice system, and that's a larger discussion of the school to prison pipeline or even the preschool to prison pipeline. Those are realities. So the education access and quality domain is extremely impactful. Additionally, children living with poorly performing schools or living in communities with poorly performing schools, that is also a challenge. There's a stress, there's a pressure point there. The stress of living in poverty can affect a child's brain development, making it harder for them to do well in school. And so the objective around education access and quality is, what do interventions look like? What do they need to look like? How are they proactive? How do we help young people? How do we help families pay for college? And how does that look as it relates to long-term health benefits? That's the formula when we're talking about social determinant of health domains, and specifically the education access and quality domain. The next domain I want to explore with you is healthcare access and quality. Now, the goal here is to increase access to comprehensive, high-quality healthcare services. Now we looked at disparity and looked at the different types of disparity, and I focused on treatment and coverage, especially through the larger lens of health equity as we're examining it. But so healthcare, so many persons in the US don't have the healthcare access that they need. They don't have the services that they need. So forward thinking with Healthy People 2030, there is an intentionality around focusing on improved health to help people get timely, high quality healthcare services. And I'll reiterate, timely, high quality healthcare services. The data points that were shared previously highlighted the fact that, unfortunately, even with diagnosis and potentially with treatment, we would see that persons would have substantial delays with in-office and clinic visits, which is very much a reality, unfortunately. 1 in 10 persons in the US, DOH shares, they don't have health insurance. And so persons without insurance are less likely to have a primary care provider, and therefore you can't afford the healthcare services and medications that you need. So in thinking back to the physical health domain that I stepped through and chronic disease that we talked to from a data point space, it is mission critical to ensure that we pull together, that we really brainstorm strategies to increase insurance coverage, for making it a priority for persons to have preventative care and treatment for chronic illness. Moving the needle from health disparity to health equity requires such. The last two domains of the social determinants of health are neighborhood and built environment, and social and community context. So providing a little bit around neighborhood and built environment, I want to step through that. Neighborhoods are where persons live. Neighborhoods have a huge impact on health and well-being. And Healthy People 2030 speaks to the fact that your neighborhood needs to be a health and safe place to live, work, learn, play. Because among the ideals of the vision mission of the social determinants of health and proactively moving forward strategy-wise is to integrate how we can create and cultivate equitable spaces that are healthy, that are safe, where we live our everyday lives. So, many persons in the United States live in neighborhoods with high rates of violence, perhaps unsafe air and water. That's the environmental injustice conversation. You also have other health and safety risks that are folded into the equation as well. Oftentimes, racial and ethnic minorities and persons with low incomes are more likely to live in places with these risks. And so we talk through the correlation between the two. Quite simply, persons are exposed to things at work, in their environments that impact their long-term health benefits. So in their workspaces and also in their living spaces. Interventions are mission critical to help pivot this. Policy changes, local, state, federal level are also needed as well to reduce health and safety risks and to help promote health. So when we talk about the neighborhoods, those are, the places where we live, work, learn, and play, but then also too, our built environments, maybe our office spaces. It becomes extremely important for us to make sure that people have opportunities to reduce wherever health and safety risks and promote health in those spaces. And what might that look like? Perhaps that's looking like adding sidewalks. Maybe that's adding bike lanes. Improving health and quality of life can look multiple ways. It's our strategy and our planful examination and exploration that helps us move the needle on this. The last domain around social determinants of health is social and community context. So we need to increase social and community support. Persons' relationships and interactions with family, friends, coworkers, community workers has a huge impact on our health and well-being. We have been, in the pandemic space, we didn't know what we didn't know as we moved into that space over the past couple of years. And so increasing social and community support has risen to the top as we look at positive relationships and the huge need for positive relationships at home, at work, in the communities to help remove or reduce at least negative impact. Negative impact can be very impactful, especially for children, perhaps where you've got children in communities, they're perhaps being bullied. We need to think of interventions to help people get social and community support to help them thrive. Helping people get the social support they need helps them face challenges in a different way. It helps them address dangers that they might feel like they cannot control. So how can we better support that? So the domains of the key domains of the social determinants of health I've stepped us through. And now I want to talk a little bit about impact, because we've stepped through the key domains. We know what the key domains in terms of economic stability, education, social and community context, health and healthcare, neighborhood and built environment. But what about impact? Impact can be positive and impact can be negative. And so along the lines of the trajectory, right, of moving us from health disparity to health equity, I wanted to share a bit about how poverty inhibits access to foods and safe neighborhoods, and that higher levels of education influence better health. Social determinants of health are conditions in the environment that people are born, live, learn, work, play, worship, and age that affect the key phrase, quality of life and risk. Now, when resources are available, and that's the key piece, when resources are available to overcome negative social determinants, there's a huge impact in that positive strength-based way on population health outcomes. Among the recommendations in terms of expanding our framework was to revisit that root cause analysis piece around population health outcomes. And that requires us to look at what's working and what's not working, the positive impact, but also the negative impact, and how that translates into one's quality of life. Now, negative impact of the social determinants of health is something that we can't ignore. We talked about the social determinants on its face by definition, but then what happens when they're negative social determinants? Because that's also impactful and important for us to address as well. Negative social determinants of health can impact an individual's knowledge about healthcare and resources. So information sharing can be extremely impacted by negative social determinants. A child born to parents who haven't completed high school are more likely to live in environments that contain barriers to health. So what you know about your health, what you don't know about your health is very much impacted potentially by negative social determinants. So that's how we need to work with the course correct that. Poor individuals who are white are less likely to live in areas of concentrated poverty than compared to racial and ethnic minorities. Again, rising to the top, the institutionalized racism component that is at the crux of this conversation. As income decreases, the likelihood of premature death increases. There's a link between the likelihood of smoking, shorter life expectancy, and lower income. So the correlational value from negative impact of social determinants of health is quite high. And it really requires us to examine it and unpack the root cause analysis around negative impact to truly get to that space of manifesting the strength-based aspects of the social determinants of health. Now, the environment in which an individual lives can impact future generations, right? Stress related to disparity when we're talking about health it's oftentimes superimposed. We're talking about a confluence of things. Growing evidence truly shows that the negative impact of stress on children and adults, that it goes across a lifetime. It's embedded discrimination is something, is a sociological conversation that is brought to the fore at present. Commonly referred to kind of chronic exposure to social environmental stressors, there's wear and tear that put you at a higher health risk. That's very, very true. Now, Healthy People 2030 helps to move the needle on this, to help craft objectives, measures, to really help us operationalize the discussion around, okay, so we know that health inequity exists. We seek to move to the space of health equity. We know that health disparities, as we've so named them, are key. So with that, we have the Healthy People 2030 objectives and measures, where we have a vision in which all people can achieve their full potential for health and well-being across a lifespan. That's the vision. But what does that look like? And so there are 8 broad measures that really talk about how do we get there, with a core objective of really getting a sense of how public health issues and evidence-based interventions and reliable data help us to understand these better metrics. Now, the overall health and well-being metrics, I do want to introduce us to as a part of this larger macro strategy for Healthy 2030. Overall being life expectancy is one of the key health metrics. Life expectancy at birth, free of activity of limitation, is our overall health and well-being metric number 2. For number 3 is life expectancy at birth, free of disability. For number 4, life expectancy at birth in good or better health. Number 5 is life expectancy at birth. Number 6, free of activity limitation. Number 7, free of disability. And number 8, respondent assessed health status. What does your health status look like? Is it good or better health? So these are overall macro level metrics, overall well-being metrics that 2030 that Healthy People 2030 is looking at. And what the primary objective of Healthy People 2030 is really rooted in a mission to promote, to strengthen, and evaluate nationally efforts to improve health. Now, when we look at the guiding principles I'll share with you are, achieving health and well-being requires eliminating disparities. That rises to the top. Achieving health equity and attaining health literacy. So, when we think of ultimately our overarching objectives and goals, we seek to promote and achieve health and well-being nationally, and to reinforce the need for shared responsibility. That's at the state level, it's at the national level, community level, and infuses all stakeholders. So we're talking about public, private, nonprofit sectors to really promote how do we achieve health in the way that we need to. Additionally, it talks about investment. If we are truly committed to health equity, we need to invest in how do we receive and how do we actualize full potential for health and well-being, and how that benefits society. Like, what does that look like? Not just in theory, but in application. Ultimately, with the goals of Healthy People 2030 and the foundational principles, we're seeking to attain the full potential of the population from a decision-making space, but then also from a policy formulation space as well. Now, within those principles, we've got our overarching goals, and I've given you some of the metrics that we seek to operationalize, but I also want to share with you the overarching goals in terms of what, from a targeted space, from an action plan space, what do we seek to do? So overarching goal-wise, attain healthy, thriving lives and well-being free of preventable disease, disability, injury, and premature health. Another goal is to eliminate health disparities, achieve health equity, and attain health literacy to improve the well-being of all. Another overarching goal is to create social, physical, and economic environments that promote the full potential for all. And then the last 2 goals I'll fold in together, whereby we promote healthy development of healthy behaviors. That's when we're talking about the built environment versus our neighborhoods, but then also too our social and communal spaces. How do we create habits that become a part of our life stages. At the same time, while we're having these conversations, we have to engage leadership, we have to engage constituents, and we have to go across multiple sectors to be able to be successful. Now, our plans of action, the plan of action around how to get to health equity, moving that needle, moving beyond the health disparity space and utilizing the diunital reasoning where we are not in our silos, but we are being multidimensional in terms of how we actualize our need is a plan of action that infuses setting national goals with measurable objectives. We need to quantify our progress. We provide accurate and timely accessible data is a plan of action, is a piece of the plan of action that's being proposed. Additionally, facilitate the development and the affordable means of health promotion, disease prevention, and treatment, and what that actually looks like. Now, the framework I have in front of you is in fact the Healthy People, the framework around setting the goals that I made mention of. You seek to set, provide, foster, share, support, report, stimulate, and facilitate. We want to set those national goals. We want to provide accurate and timely data, foster impact through public and private efforts. This is the stakeholder conversation, providing tools, making sure that information sharing is not siloed, that it is across communities. We want to share and support implementation of evidence-based programs. We've got so many empirical sources that can help drive this conversation around needs relative to gap analysis and resource allocation. Stimulate research, be innovative, and then facilitate the development of affordable means of promotion of disease prevention and treatment as shared previously. This is the framework that needs to be engaged, but applied within a diunital reasoning logic in terms of how we move forward to get to a space of health equity. Now, what we can't do is we must ensure that in our journey that we talk about strategies for culturally specific solutions. We cannot have this conversation. We cannot be effective in this conversation. We cannot be effective in this action plan without infusing strategies that are culturally specific in orientation. So this means really looking at, from a race equity space, underserved needs, look at cultural targeting, look at cultural competence, and I would even add cultural humility. Let's look at patient-centered care and health literacy. People first care interventions that promote individuation. Something for us to consider. These interventions, they promote providers to make a conscious effort to view persons in terms of their individual characteristics rather than group membership. We need to put that hat on. And we have got to be aware of our own biases and our own stereotypes, because we know that interventions can take place at the systems level, but they need to be engineered universally, and they need to be equitable in scope. They also need to be preventative, especially when we talk about the need as it relates to chronic disease and how we manage chronic disease across communities of color. Now, also when thinking about strategies for culturally specific solutions, we have to have culturally competent, but also infuse a lens and a practicality of cultural humility that seeks to improve the ability of a provider to provide healthcare for persons in specific ways, meaning we have a healthcare system that factors in the idea of cultural humility. We have interventions that prioritizes the population to help navigate this patient people first intervention philosophy. Interventions in and of themselves, we need to have interventions that first and foremost address physical barriers to access. And we also need to have interventions in place that educate providers about conditions and about targeted populations. We cannot be effective without structure and strategies that are culturally specific in orientation as we seek to move, yet again, from health disparity to a space of health equity. Thank you very much.
Thank you, Dr. Jackson. That was a very insightful and informative presentation. And I hope that the audience actually saw the correlation and the connection from yesterday's presentation into today's presentation, and how social determinants of health really do play an integral part in our overall health and well-being. So at this time, because that was a very rich presentation, I learned a lot. So I'm sure that a lot of other people learned a lot of information as well. We're going to take a 15-minute break and we'll return here around 2:15 for the panel conversation. So we'll take a quick 15-minute break and we'll be back shortly. Thank you. Does anyone have any questions? I didn't see any in the chat, but before I let you guys go, are there any questions for Dr. Jackson?
We'll just wait like 1 minute.
Okay, we're going to wait 1 minute to see if anyone has any questions. Okay, so we have no questions. We're going to take a 15-minute break and we'll see you guys back here at 2:15. Thank you. Thank you so much, Dr. Jackson. That was very informative. I know I learned a lot.
Great, I'm glad. And then for the 2:15, I'll do some table settings so that we can connect the dots even more so with our mental health. But thank you, I'm glad. I enjoyed it.
Okay, yes, thank you. All right, I'm gonna take a quick break real quick.
Let me get some water myself.
Yes, okay. We'll get started in about 2 minutes. Thank you, and welcome back to day 2 of the Mayor's Health Equity Summit. Dr. Jackson is going to have a panel discussion along with Dr. Palmieri from Summa Health, Dr. Sierra Dennis Morgan from Minority Behavioral Health Group, and Dr. Douglas Smith from the Adam Board of Summit County. Dr. Jackson, I'll turn it over to you.
Excellent. Thank you so much, Tamika. Good afternoon. It is great to be back with everyone this afternoon again. Looking forward to an exceptional conversation around mental health. And the keynote address was able to give some empirical supports around what we're seeing. And so I look forward to exploring the discussion even further with my colleagues this afternoon. So to begin, I would look forward to if each panelist could give just a brief introduction as to our audience. That'd be phenomenal. Dr. Palmieri, can we begin with you?
Sure. Can you hear me okay?
Excellent.
All right. Good afternoon. My name is Patrick Palmieri. I'm a clinical psychologist. I am the chief psychologist for Summa Health and the director for the Summa Health Traumatic Stress Center. I've been doing that for 17 years here, and part of my roles also have included being involved in some integrated care efforts at Summa, so integration of primary and behavioral health care. Play some training roles and involved in research as well.
Excellent, thank you. Dr. Dennis Morgan.
Good afternoon, everybody. I'm happy to be here with the panelists and with the community. I'm the clinical director at Minority Behavioral Health Group, which is a community mental health organization, a behavioral health organization here in Summit County. And we specialize in providing culturally specific services to underserved populations with a special niche and focus in working with Black folk.
Excellent, thank you so much. And Dr. Smith.
Good afternoon, thanks for having me today. So I am a psychiatrist, forensic psychiatrist here at the County of Summit Alcohol, Drug Addiction, Mental Health Services Board, where we fund around 25 agencies, some partially, some largely, their main funder actually. And then we also evaluate the services and then plan to fill gaps in the community. So this topic's right on target. I also wear a hat as on the board of trustees for NAMI Ohio, that's the National Alliance of Mental Illness, and do a lot of work at Neomed with integrated care, including their new ECHO programs. In fact, today we're in a training to become a super hub. So I've left the training for this purpose because this is obviously a very important topic. So thank you.
Excellent. Thank you, panelists. I greatly appreciate you introducing yourselves. So we're going to talk about mental health this afternoon within a series of domains. And I do want to do a little bit of table setting around, what we want to detail this afternoon. Firstly, I think some of the data that was shared previously, it highlighted the fact around mental health, specifically around diagnosis and treatment. So I would really love to hear from you as to method and approach around service array when we talk about diagnosis and treatment. African Americans are more often diagnosed with schizophrenia, was one of the data points shared, but less often diagnosed with mood disorders compared to whites with the same symptoms. So we're clear on biases that are within our systems, whereas we have higher proportions of imprisoned persons with psychosis than other races as well. Prevalence of individuals with mental health needs are involved in the criminal justice system, which ties well to how we'll close out this summit. So what does that mean as it relates to treatment plans, intervention models? Quite simply, African Americans are offered medication and treatment at lower rates than the general population. And then access to services. Among the topics I'd like for us to explore within the next hour is around treatment plans and intervention models, around access to services, access to mental health supports for African Americans that we know is low, access to primary care, and even lack of insurance coverage, all of those things. But to begin, I would, and if a round robin format, if that works well for you all, I think what we can gauge, but it's a fluid discussion. So please feel free as we, we can go whichever direction I think our conversation takes us. And I'll begin with you, Dr. Dennis Morgan. What do you find to be the relationship, or for you, what's the relationship between equity and mental health? And what does equity in mental health mean to you? And how would you define it?
Yes. So it's interesting. So as I sit with that question, I think that the relationship is significant. Even as you talked about in your presentation, equity for me and how I think about it is within mental health. So it exists within how we understand what mental and behavioral health is. And essentially, I like to think about it in connection to justice, which is a virtue and value that for me fits and sits very well. And so when I think about equity, I think about it in a couple of ways and try to even simplify the idea. But we know that equity acknowledges that in this country, there have been and currently are so many systems of oppression that play out at high level and just are so insidious that impact mental health and a variety of other health disparities. And so equity is the understanding that there is not equality. There hasn't been for many people and still is not for many people. There's not a lot of fairness and that there hasn't been this initiation at the same start point. And so I think that equity is about considering what makes sense when we talk about it in relationship to mental health. And even that differs because of the impact of oppression and racism and bias and socialization. And so we have to look at all of that in connection to this definition of moral righteousness and ethics and rationality and law, kind of how we have defined it formally. But even natural law, because when we talk about our laws in this country, we know that there's a lot of work to be done in that area as well. So it's about treating people, of course, how they deserve to be treated. And I keep saying at the same time, we know that looks different for people, because when we talk about Black people and brown people, we've been treated as less deserving, of less value, of less worth. And when we think about that too, we think about people having to do something or be something specific to be worthy, valuable, or deserving. So equity for me and in relationship to mental health is very foundational. It's about living right and making things right. And so I know what we're talking about more and more is how do we do that? So it's about justice when I think about it in an African-centered way, which is a part of, as we know, morality and natural law.
Awesome. Thank you so much. And I love how you were flowing into kind of equity and equality, because we will see the difference kind of all things being equal, right? Versus equity's resource allocation. And how do we level that playing field? That's a very different way for us to look at this conversation, because oftentimes we got quite comfortable with saying, oh, well, it's equal. Well, things are equal. But then when we really pivot and truly mean equity, it looks right. There's an amazing visual, and I'm sure the three of you are familiar with it, where it has three young persons at a fence, and equality, everyone's kind of peeking over the fence. And then equity, though, you level the playing field. You've got different stands, so that guess what? Things look different now because resource allocation looks different in an equitable space versus a space that's just equal. So I definitely appreciate your distinction there, Dr. Dennis Morgan. Thank you. Dr. Smith, yourself, the relationship between equity and mental health, and what does it truly mean to you, and the definition?
Sure. So I think most of our stance at the ADM board and my personal stance as well is really from an equitable point of view is trying to make sure that all of our resources, they come from mostly 80% about approximately come from the tax base here in the Summit County area based on people's real estate taxes. About 10% come from federal dollars, about 10% come from the state. So our attempt, and I think it gets better every year, is to make certain that we are in every space in the community so that we again, about 25 or so agencies. We also sometimes give money to SUMA, Cleveland Clinic, and so forth for projects. And the goal is to make sure that we are in all of the spaces, and we've got a range of community coalitions that individuals of color and not of color are able to attend. We've got certain agencies that are specific to the African American population, such as minority behavioral health. And one of the big problems we're having with equity actually gets to staffing workforce more than I think services. We are finding it very difficult to hire enough people, let alone enough people of color across all of our systems. And that ends up leading to wait lists. I think actually minority behavioral health may have a wait list now, partly for that reason. And so that to me is where we see the lack of equity in terms of access is really a high level. It's on our list of high level items at the ADM board. And I can go into more of any of those details, but from my perspective, I will say as part of all this is an attempt to get more. I've heard a lot of words for this. I like the word cultural intelligence as a word that we're trying to get to make sure that more of our staff, because we're not going to find, apparently, at least not rapidly, enough clinicians of color to make sure that they all have the ability to interact effectively with people from various cultural backgrounds and in culturally diverse contexts.
No, excellent. Thank you, Dr. Smith. And the point that you make, that service delivery piece is huge. In terms of either the wait lists or delays, because that's ultimately impacting treatment, which is an exceptional challenge. I can definitely appreciate your sharing about the cultural intelligence piece. And yes, there's the lexicon keeps expanding, right? In terms of cultural humility, intelligence. What's the verbiage we so seek, right? But interestingly enough, because less than 2% of the American Psychological Association members are African American, some worry that mental health practitioners are not culturally competent to treat specific issues. So to your point around a need, a gap that is very evident, and that's clearly within the American Psychological Association, but I'm sure that's probably across professional spaces where that's a challenge and of concern. So thank you so much. Dr. Palmieri, the question relative to the relationship between equity and mental health, what does equity in mental health mean to you, and how you define that terminology?
Well, and thank you for the question, and thanks for involving me on the panel. I appreciate it. I would just echo a lot of what the other panelists have said already, and what you presented earlier today too. I think you defined it well as health equity or mental health equity being the right to access quality services that are fair. There's a fair opportunity for everyone to access those services regardless of their socioeconomic status, if they're in a one of many different marginalized groups historically. So I think that, we're trying to create equal opportunity, and there are many and have been many obstacles to that that been mentioned already today, and that I think that we have a lot of work still to do to overcome. And some of it is, as Dr. Smith was alluding to, kind of this idea of cultural competence, whether it's developing the workforce, in terms of who the providers are within the mental health world, but also developing the workforce to improve our cultural intelligence, or we might call it cultural competence, and just training people on biases, often implicit biases, and really just making that a point of emphasis, because we need to develop, and especially in a mental health, but in all healthcare settings, we need to develop, trusting relationships with patients. And, we need to be able to understand each other, communicate effectively with each other, develop trust. And I think practicing cultural humility is really important, because and I'll just give an example. This is not, it's kind of a little bit of a different example, but most of my career, I've worked with military veterans who had struggles with military trauma. I've never served in the military, right? So there's a disconnect there in some ways, and it requires a lot of effort to develop that trust and understanding. And for me as a provider to really just own up to the fact that, I don't know exactly what it's like for you to have gone through what you've gone through. I've learned a lot. I've learned from a lot of people, and I'm going to continue to learn, but kind of making sure you come at it in that way, just owning up to what you know and what you don't know, I think goes a long way to developing that relationship, especially when we're talking about cultural competence.
Awesome. Thank you, Dr. Palmieri. That infuses a lot of the critical indicators that we need to address when we exhaust the conversation about how to move the needle from health inequity to health equity, and being very cognizant of the fact that health disparity is among the root cause challenges. So, and you pivot us nicely to the next question, which is asking the three of you, what does mental health, what does that look like in community? So I appreciate how we defined it. And I think we start to head in that direction a little bit. But what does it look like across communities? Because when we look at statistics and some of the data shared previously, we know that African Americans are living below the poverty level twice as likely to have serious psychological distress. There's correlational value there, right? More often than not, there's sadness, hopelessness, worthlessness that's living within communities. And so when we talk about what does equity and mental health look like in communities, what does that look like for you? To that same end, I'd be curious to hear what inequity looks like. So kind of on one side, what does equity in a community look like? How does that play out? In your mind's eye, in your professions, in your expertise, what does that look like for you? But then also on the conversely, what does inequity look like? And then we'll close out our panel discussion around method and approach, because we've table set around, okay, this is exactly what inequity looks like. This is what I think, big picture, pie in the sky, what equity looks like. But then how do we move that needle? So Dr. Smith, I'm going to start with you.
Sure. So what does it look like? So I guess from a equity point of view, what you'll hear anybody at ADM say is that our goal is to have a no wrong door or no wrong phone call nowadays under COVID approach. That is, we say that to everybody, regardless of color, background, what have you, please come in. The other thing I should say about the ADM system, using a broad word, is that mostly our dollars, in fact, go to people who are underserved, underinsured, or uninsured. So given, as your excellent talk in the previous hour, we are likely to be hitting many more people of color than some other systems might, because that's how we're structured. That's who we're not as likely to get a lot of people with their own medical mutual or other types of insurance. So from a equity point of view, we might actually be skewed toward the other group of individuals to start with, of all races, but that, as you've said, there's a higher percentage of individuals of color that may be in that category. So when we're looking at this, that is our hope at achieving equity. We also look at maps. So we do a lot of heat mapping of data. And of course, the goal there is to see where are more people getting services and where are less people getting services. Then we drill down to see, do we need to somehow put services in that area based on the zip codes. So let me give you an inequity example real quickly, which I don't know if it's inequity, but I think it's important to highlight. So for most of the COVID, since we all have to mention that at least once during every talk, so during COVID, we've done fairly well actually as a system. We did not see the increase in death by suicide. We did not see the increase in opiate overdose deaths in 2020. However, from about September of 2020 forward, it's actually a little better right now, but we'll say for some months, we did see a small, but every bit's an increase, it matters to us, a small increase in death by suicide and also death by opioid overdose in particularly African-American men. And so we have two task forces that work on this. Again, anybody in the public can join them, and trying to drill down on why is that? What changed that we had, and what it represents percentage-wise is a bigger increase. The numbers are a few people, but the only good numbers in either of those categories is 0. So we don't want anybody dying by suicide or dying of an overdose. So that might be an example of inequity. We're right now working mightily to figure that out. Is that the case? Or did something else change that has led to the increase that otherwise, we haven't seen that in the other populations?
Interesting. No, thank you for that example. Dr. Palmieri, I'll ask you next relative to what inequity looks like in communities, across communities. We will delve into treatment, diagnosis, service array as we flow through this continued discussion. But for you though, what does inequity in mental health specifically look like across communities? And then also the flip side, that inequity component as well.
Yeah, so I look at most of these through the lens of the role that trauma and adversity plays in people's lives. And we know that, trauma and adversity kind of happen in a variety of contexts and a variety of ways and settings. There's trauma and adversity that can happen, where you live, in your neighborhood, where you work, where you go to school. And we know that there are differences across neighborhoods, across zip codes, across different regions on the amount of community violence there is, for example, or other types of trauma and adversity that have a negative impact on people's health and well-being. So I tend to think of trauma and adversity as being drivers of health disparities, drivers of health inequity. I think that one of the reasons why we have such disparities in health outcomes is because of adversity and trauma. And we know that from many studies that, especially in childhood and early childhood and adolescence, that the more types of traumatic or adverse experiences one is faced with, the higher rates they have of all sorts of negative health outcomes later in life. It could be physical health problems, could be psychological challenges, could be other behavioral issues like substance use or alcoholism, and basically any important and costly in terms of not just dollars, but in quality of life and societal cost. Any of those harmful outcomes that we hear about in the news today, obesity, diabetes, cancers, alcoholism, suicide, depression, you name it, they all have very strong correlations with childhood trauma and adversity. Yeah. And so I always see that as the driving force in creating disparities and inequities. And so for me, what would be, to achieve equity would have to address childhood trauma and adversity as kind of a root cause, using that term earlier. There's a root cause of a lot of these health disparities, and and I think there's a lot we need to do and change within our system to be able to effectively address that issue.
Excellent, thank you. And as you were sharing, it did link back to what Dr. Smith was sharing around relative to suicide, because there was a data point that came to mind where you have African American are less likely than white persons to die from suicide at all ages. But interestingly enough, African-American teenagers are more likely to attempt suicide than white teenagers. So kind of to your point, Dr. Smith, about the variable that you shared, the indicator that you shared within your community, and Dr. Palmieri, the reality of childhood trauma is extremely impactful. And the fact that across the board, where you may have African Americans less likely to die from suicide at all ages, you do have a subpopulation of teenagers, though, that are more likely within the African American community to attempt suicide than their white counterparts. And I think that is definitely for us to note. Dr. Dennis Morgan, I would like to close out the question around equity in mental health, what it looks like for you, what inequity in mental health looks like for you across communities. Be excellent.
Yeah, I think I would like to build upon what Dr. Palmieri is speaking about when we think about trauma. And I even think about that in connection to, I can't reference oppression enough when we talk about the health disparities and inequity and achieving and attempting to move towards equity. And so thinking about that and childhood trauma, when we think about weathering, when we think about toxic stress, all of those things in connection to that's what kind of causes it. There's a correlation. And that's when we look at what it looks like our infant mortality rates, right, which we talked about yesterday and we're focused on as a community. And so I think that equity looks like us trying to prevent, which you spoke about in your presentation as well, how we prevent this trauma from occurring, how we kind of maneuver it and help facilitate healing through the trauma and et cetera. But also not only childhood experiences, adult trauma, all in connection to also racial trauma and a variety of different cultural and generational trauma that people have experienced as well. So I just wanted to highlight that because I can appreciate the focus on that and the impact of that as well. But when I think about too, what equity, about equity and about this question, it makes me think about this consistent centering of one's like historical, cultural, and present and future healing and health that's grounded in a person's values and grounded in justice, right? So it makes me think about always this consistent ongoing return to centering someone's experience and voice and who they are and their value. And so I think that that's what it really looks like within our community, across our community, is how do we do that? And how does that look different for individuals? And how does that look, what kind of themes can we find of what that needs to look like collectively as well? But really about decreasing and providing protection against kind of this exposure and experiences of different traumatic experiences, whatever that may be, and even how racism might fit within that. But in equity, in many ways, it looks like what a lot of the data suggests. It looks like now, it looks like us over-pathologizing clients and misdiagnosis. And I think that that's what we see that it looks like. That's what we're living in many ways, unfortunately.
Gotcha. Oh, thank you so much. I definitely appreciate the protection, utilizing that language, because what comes to mind most immediately is what protective factors and risk factors. We have to infuse that lens into this discussion as well when we think about trauma, when we dissect and kind of unpack what perhaps almost even, back to like Maslow's hierarchy of need, right? We're thinking of like protective factors, risk factors, and stability. And how we get to concrete root cause analysis to pivot for that course correction, and what that might need to look like from an action space, right? So thank you all. I greatly appreciate your insight around what mental health looks like across communities, what equity looks like across communities relative to mental health and inequity, because it's helpful to have the comparative. Because I wanted us to shift now to those domains, the domains of inequity, and really kind of step back and, of positive diagnosis, treatment, access to services as ones that rose to the top, ones that definitely, when we think about it, and Dr. Smith, as you were talking about delay, one of the data points shared was around in clinic visits and delays in getting those opportunities, which as a byproduct of not getting the treatment or medication and or therapy that one might need. What might be some additional areas in addition to treatment, in addition to diagnosis and access to services that you would identify? And then of the areas identified, I would love to hear from you in terms of sharing how might we prioritize them? Like, what are the ones that you feel like, okay, as we identify these areas of inequity, we need the most most traction. These are the top two. So I believe in our round robin, I think we are to Dr. Palmieri. I believe I will start off with you with this particular question.
Okay, well, I mean, I think there's a lot of topics. I'm sure we all will have kind of thoughts about a lot of them. I'll just start off with one that's not, no particular order here, but I think one of the things that's really an important opportunity, but also one we have to be, kind of strategic and thoughtful about is telemedicine, virtual healthcare, telehealth, whatever you want, whatever word you want to or label you want to assign to it. It has such opportunity to help remove barriers that traditionally have helped drive disparities. So whether that is, lack of access to, reliable transportation, not having childcare coverage that will allow you to, get to your doctor's office. If the weather is horrible, you miss your doctor appointment. There's all sorts of things that, are pose barriers to accessing the care that people need. And one thing the pandemic has done is accelerated all of the kind of telemedicine efforts that had already started. They were underway, but not anywhere near to the degree to which we see now. And it's still expanding very quickly and broadly. So I think that the advent of the uptake of telemedicine has great opportunities for helping to improve equity. One thing that I think is important to note about it, though, is if we're not careful about it, because there are also disparities in access to reliable high-speed internet, for example. So we can't just kind of turn everything over to a telemedicine or virtual framework and expect that that's going to solve all of our access problems. So there are disparities in access to high-speed internet. There is not always even culturally informed training for people on how to best interface or interact with the technology that is being developed and used throughout healthcare much more frequently now. So I think it's important that we're careful to ensure that we're addressing the technological divide. And one thing that the recent infrastructure bill that was just signed, it has a lot of funds in it to improve broadband access throughout the country. And I think that's going to be really key, and we're not going to be able to maximize the value of telemedicine, for example, without in its relation to health equity, without ensuring that reliable access to high-speed internet. So that's one example on it.
Okay, no, that's excellent. Thank you so much. Appreciate it. Dr. Dennis Morgan, for you, in terms of areas of inequity, we highlight, of course, diagnosis, treatment, service array. Dr. Palmieri has talked about telehealth and telemedicine. What is another potential area of inequity for you? And in terms of potentially prioritizing, what do you think might rise to the top in terms of those areas of inequity that we need to get concrete traction around?
Yeah, so I want to go back for a moment just because I had an afterthought of the question that we were speaking to before. And I think that also equity in mental health, and I think we know this, I just want to highlight this. I think it looks like what we also have been talking about, right, is improved quality of life in our community for individuals. And it looks like increased peace. It looks like people being resourceful. It looks like increases in self-esteem and how that's been demonstrated behaviorally as well. And it looks like, and we talk about resourcefulness, we talk about being resource rich, but what are the barriers in accessing those things? And what does it really mean to be resourceful, even within one's community? So I think about that too, in connection to like, what does mental health look like in practical ways, some ways that we can't see as much, but we may see in behaviors in healthy communities and healthy people. But to this question, this current question of inequity in mental health in areas to identify, I think that those three that have already been identified are so important and have to be prioritized. And I think that there are things that have also been highlighted that fall within those or overlap or in relationship as well. So I think that bias is huge in how we address that, whether that's through training with a focus on cultural humility, competency, intelligence, like whatever term we want to use, and then how we continue that, right? So this idea of like how often it takes place, what does it include, and kind of how are you helping people to be accountable or helping to continue in that process, because we're always being socialized. And so we can't have just this one set of training every so often to expect and think that all of these things are going to be deconstructed as we're attempting to reconstruct. So I think that that's really, really important when we talk about bias in connection to diagnosis and assessment and treatment and services, is just really how we address bias and how intentional and how many resources we're willing to pour into that area. I think that another area within inequity and mental health that is important to speak to is one that I think has been highlighted by Dr. Smith, which is this idea of the providers, which kind of overlaps as well as retention of staff, training of staff, not having enough staff, but how we take care of the providers that we have and how we help the healers to heal, and what things that we're doing within system-wise to take good care of the providers that we do have and help them to grow and be exposed and, learn and et cetera. I think that that is definitely something that has to be at the forefront all the time, because these providers are doing so much work in connection to diagnosis, treatment, access, et cetera. So I think that that's really, really important to highlight as well. And lastly, I guess as far as prioritization, it's hard for me to say what is a priority, right? Because I think that we all have to know what our purpose, our passion, our role is, what's our low-hanging fruit, and how we kind of prioritize within ourselves and the systems that we work in and in a relationship to. So I think that if we can identify that individually and collectively within the circle that we're in, I think that these things can overlap and be addressed collectively. I think that order is important, but I think that all of these things can be addressed if everybody knows what their role is and kind of how they move in that way. And that's that idea of collective work and responsibility.
Oh, thank you. I mean, those are just some great nuggets in what you shared around the cultural humility piece, because, as connecting the dots between what Dr. Smith had said previously, and of course, Dr. Dennis Morgan, what you shared around, the bias piece, and you said socialization, kind of really keyed into, I think of the cycle of socialization and Harrow's cycle of socialization, and how integral that is in terms of what's been defined as norms for us, right? That we didn't even quite recognize when we were in our peer groups, our education groups, our family groups as we were developing, because that bleeds into us as providers. And so that what comes to mind is that the people first care intervention, promoting that individualism component where we prompt providers to make conscious efforts to view people in terms of their individual characteristics as opposed to group membership, but then also being aware of your own biases and your own stereotypes. It forces the hand relative to that. So thank you. Dr. Smith, I would be curious around your insight on this question, sir.
Sure. So certainly both panelists did a great job with that. I'll do something different just to not be redundant, although I agree with what was said by my two excellent colleagues there. So I'm going to say, and maybe it's a new phrase, but informational inequity, which I think decreases the likelihood people will get access. It also decreases the likelihood that they will recognize if perhaps a diagnosis doesn't ring right or what have you. I'm not just the person, but the family, because the person may not have insight, but the family might. And I'll use an example because I think the solution is intentional collaboration of all individuals. So we cover all the ethnic backgrounds, which is getting actually more challenging in the Akron region than less, because we have a number of individuals coming from other cultures as a sanctuary city that also get into this mix of how do we make sure that we're working with them and giving them informational equity. I'll give you an example. I think our science as a country has been very poor, which is a minimal word, for how we've treated individuals of color in terms of our research studies, in terms of some of how they were conducted inappropriately, how we don't tend to do studies that include individuals of color. And so we did actually partner very intentionally. Pastor Boyd, or Coach, as he goes by, Kent Boyd at Love Akron, reached out to the ADM board. I partnered with him then. And so I did a number of I guess you'd call them webinars, basically live events with Love Akron, to try to really give the true information, and that tends to touch more of the African American population, about the COVID studies. About literally, I went into what were the ingredients, what percentage of the individuals who were studied were African American, which honestly, I can tell you this is a hopeful statement I'm giving you. It was the first time that I've seen studies where 10% of those individuals studied were African American. And one of the studies actually was was somewhere closer to 18% because they did the studies in Brazil as one of the sites. But the point is that we tend to get studies on all medications of all types of treatments, not just psychiatry, that tend to be Caucasian individuals in this country. And then you get into questions about, number one, scientifically, well, is that accurate? Are there different metabolic issues? And there are some across different cultures, whether it's Ashkenazi Jewish population, they've got certain issues that pop up in that population. Caucasians have certain individuals. You mentioned, I think in the last hour, hypertension with Black Americans. So there's this issue of getting the right information out intentionally. And in that case, the goal, Kemp Boyd's goal and my goal through ADM board was to improve understanding that, hey, at least if you decide to go get vaccinated, that there's logic to it, that it was actually studied on enough people to give you a sense of safety, which I don't think otherwise many people would have had, if especially people of color, because historically we've not done well with that. So that's just one example of being intentional about informational equity. I'll give you another one because I think to the extent that we do a lot of this now, and I hope this seminar, your talk, and both days starts this moving even more in Akron and Summit County. I'll give you an example that several years ago, the United States Services Preventive Task Force suggested, and then the American Academy of Pediatrics agreed, that we should be screening everybody age 11 and up for depression, which includes a question about suicidality. And this is of all colors. The pediatricians jumped on board. And so what has happened now is that when anybody takes their child into a pediatrician's office starting at age 11, they will get screened. And number one, that's awesome because that should cover everybody. Anybody who comes into care will get screened. But I'm actually, for this purpose, I'm actually interested in the higher level part, which is that now what will happen is that those adults whose children got screened at 11, because I can tell you, I wasn't screened at age 11 for depression. I'm imagining none of you were either. That was not the norm because of another version of stigma, and that can be trauma and so forth. The net result is that when those 11-year-olds and up grow up and have children, it's going to be strange to them to not have their children screened. And so to me, this adds to the informational equity that we should all be getting have the same mindset around our own health, the same access to our own health care, and also continue that generational. And I think, so to me, that's an example. And if we could start that now, and I think it is starting, but we obviously need more discussions like this one today to get this information, this concept into the public, that maybe it'll take a generation, but at least finally we can say, healthcare, number one, healthcare is healthcare. We don't separate the brain from the rest of the body as we've done for a long time, right? It's all integrated because, as Dr. Palmieri said, he does a lot of that work at SUMA. I do a lot of that at Neomed. And so healthcare is healthcare. Get rid of that stigma. Doesn't matter whether it's neurological, brain, kidney, who cares? Substance use, all of them are the same. And that whether you're of color or not of color, it doesn't matter either. We all have the same knowledge. So there's informational equity and studies. I'm going pretty broad here, but studies will have done enough studies to prove what really works and what doesn't work.
Can I just follow up on that briefly? Because this is a topic that I was going to mention also about research in general. We're talking about improving, access and equitable access to services. So that's great to be able to access services, but then the services that are there need to be effective also, right? And they're not always equally effective across different groups of people, and there's lots of reasons for that. And Dr. Smith, kind of touched on one of them, a lot of the research, the studies that go into developing and refining some of these treatments, whether they're psychotherapies or medications or whatever, often have minority groups have been underrepresented in those studies. And so what that leads to then is, there's questions about, well, how when we take the findings of those studies, how generalizable are they to these other groups? How applicable are these findings? How much can we rely on them? And that goes towards trust, right? So, trusting interventions, trusting clinical recommendations. So this is a really important topic, and there have been improvements made definitely over the years, and they're continuing to improve in terms of inclusion of people from different traditionally underrepresented groups in clinical research. And I think that it's critical not just to improve trust, but it's critical so then when we do improve access to services, the services that are there being accessed are efficacious and effective, for everyone.
Excellent. Thank you so much. I definitely appreciate your insight, Dr. Smith and Dr. Palmieri. And the flow of the conversation has been phenomenal. So I thank the three of you for sharing your expertise. And it's so interesting as we start off kind of defining with intention, equity and inequity, what it looked like in the mental health community, and then naming specific areas of which we need traction. And then we've landed in this space of, okay, method and approach. And naturally, that's actually where we are with our last two questions. And I think, Dr. Palmieri, it was interesting as you were sharing about the efficiencies and effectiveness of services and access and the gaps that can be inherent within them. That's a perfect way for us to close out our panel discussion with our last two questions around method and approach, and action. What can we do from an action space is where I would like for us to flow with it as we close out this dialogue. The first of which is using the lenses of diagnosis and inequities that exist. And I do ask you if in fact there are additional inequity areas that you want to posit in this response. That'd be phenomenal, because through this lens of method and approach, I seek to ask you solutions that you posit. What can be some excellent takeaways that our audience can really wrap themselves around in terms of advancing, achieving equity and mental health across communities. So we'll begin there. And then the last question is around an expansive service array. We can have an expansive service array, but what if we don't have access to those services? That's a critical and effective intervention and treatment model that has to get addressed. And so I want to hear your insight as well as to a method and approach, once again, within the realm of achieving and advancing equity, what that might look like. So Dr. Dennis Morgan, I'll begin with you around our next question around method and approach, specifically through the lens of diagnosis, treatment, and those inequities that exist. What solutions that you would posit to enhance and advance achieving equity and mental health across communities?
Yes. So I think that the conversation that we were just having around research and approaches, I think is very, very important, right? And so I think that a lot of times we talk about and utilize even some of these evidence-based approaches when we consider diagnosis and treatment. And I think that we should also consider some research-based approaches that are grounded and centered within the communities, and that center the values of the communities, the people that we're also providing service to. And there are many of those, and if not even many, even if there's just several, right, or a few, those are worth considering when we're talking about being effective and considering equity. And so I would center research and culturally specific treatment approaches, theories and treatment approaches. And I'm aware of a few of those that I think are and can be very helpful, that even start at and look at even the assessment process. So even before we get to treatment, not just treatment, when we think about how we conceptualize and before we even get to diagnosis, that I think can be very helpful and important, and it's an improvement that we can make within systems. And so that also is connected to what we've been talking about around education and exposure, and how do we remain, accountable and adhere to keeping equity at the forefront, and grounded and rooted in everything that we do. I think that in everything we should be asking the question of how are we upholding equity or inequity or anti-racism or anti-oppression, right? When we consider even how the intersectionality behind and within all of the things that people experience and live within and their lived experiences. And so I think that those are improvements that are definitely a way that we can advance and enhance equity now and be working towards and within. And I think that we have to be creative as well in those approaches that we're doing. And that even though we have learned some creativity through the pandemic, right, when we talk about telemedicine and telehealth and how we access, there's so many other ways too that we can be creative and flexible in providing appropriate, comprehensive services that look at all of life in connection to mental health, because that's what we're talking about. It's not just what happens biologically or what happens within the mind. It's all of these components in relationship to each other, and how all of these components many times is what creates the distress in the ongoing mental health concerns that exist. So just centering that holistic and comprehensive approach.
Excellent. Thank you so much. I definitely appreciate the assessment piece, because the tools that will be used, the biases that are inherent in those are structured decision-making models. Like, on that front end, even before, like you said, before we get to the diagnosis place, before we're on that front end, before we get on the back end relative to treatment, and what is infused on that front end around potential biases and inaccuracies. So thank you for that. Dr. Smith.
Sure. So actually, as it happens, our executive director, Amy Wade, and I were talking about some of this yesterday, and I alluded to a little bit of it with data, but I think the good word you just used, Dr. Dennis Morgan, about accountability. I think what we're trying to do more and more of is look at the data. We want to monitor. So it's one thing to have access. It's another thing to see who's actually showing up to get the access. So we're trying to be much more intentional now and going forward in monitoring the data so we can evaluate service access and retention by demographic. Because we won't know if there are disparities unless we're monitoring it. So we're really working hard to try to partner again with our many agencies and others that are not officially funded by ADM board, because there's a large system. We were very fortunate actually in Summit County to have a large continuum of care. And although we have the no wrong door approach, we need to now monitor better to see, well, who's taking advantage of that no wrong door approach. And that may tell us if there are inequities in the number of agencies that serve diverse populations and so forth with real data. So we're really, my strong belief at this point, I think we've evolved well in the country, but certainly in the county as well, to be more data driven. So to me, that would be the way for us to really assure and then to discuss that openly. Right. So Dr. Dennis Morgan and I should be meeting periodically saying, hey, let me show you the data. Right. And let's look at this program, that program. Let's look at other agencies, who's showing up, who's not showing up based on what we know about from our census, from we know about what the demographic ought to be. And do they match up? Are we getting the right? And if not, I go back to my point about intentional collaboration. And again, data-driven helps that to say, we need to sit and talk about this. What is going on that we can't reach people? And I think that's quite frankly, a tougher task than any of us realize. We try to be part of panels and things everywhere. And so often what happens is the people who actually take the time to show up and listen, whether they're parents or families or other professionals, a lot of what's going on is they know a lot about this already. And they're, of course, therefore coming to refine their information, their knowledge, how to get access. There's a lot of other people who never show up at all. And I think all of us need to work harder. How do we get them to even show up? Because we can't give them information if we can't reach them.
Right. Oh, thank you. Thank you for that, Dr. Smith. Yes. Who's showing up, utilization, who's at the table, who has vision and voice. Super, super important aspects. Dr. Palmieri, I'd like to hear from you.
Yeah, I'd like to string maybe a few things together here. So I guess I'll start with, I think there needs to be, and this has come up during the conversation, a focus on prevention and early intervention. We know that, disparities emerge over time and they get worse and worse over time if not addressed, right? So being able to identify and start to address, early on the health issues that over time can become more severe, but also in disparate ways across groups. So we want to focus on prevention, early intervention whenever possible, to do that requires people having better access to primary care. It's kind of the gateway to health services. And to get better access to primary care, we need to have higher rates of people who are insured, at least under the current healthcare system that we have, right? And so lack of insurance is one of the huge barriers. There are other barriers, obviously. We talked about them, as well as some potential solutions to them being, telemedicine, for example. But once you have access to those services, to primary care or what have you, then I think it's important that we're implementing validated routine screening tools to identify, again, early on, what are some of these issues that maybe we can start to address before they really take hold and become, even more severe problems, or have kind of, secondary, harmful outcomes as well. But once we do those screenings and identify some of these things, we have to have a workforce then that has the expertise to be able to address the things that we're finding. And, I think and that involves cultural competence, of course. But I think really for us to be able to efficiently address these issues, I think this is where integrated care comes in, where we want to be able to integrate primary and behavioral health care, ideally in the same location. And often that means embedding behavioral health providers into primary care clinics. So they're part of the care team. So when some of these issues come up, through routine screening, there's someone on the care team that has the specialized, expertise and knowledge of mental health and behavioral health issues and how to address them. While the patient is there, and not just, okay, now we're going to send you make a referral to see so-and-so at another facility months from now because they've got waiting lists, but trying to really, address, at least initially, and get started at addressing some of these issues right in that same setting. And I think to do all of that, just to kind of pull back into more of a systems level approach for a minute, to do all those things requires more of a population health approach systemically, where we're focusing on value-based care and not fee-for-service volume-based care. So we have to really align the incentives so that healthcare organizations and providers, are operating this way. And we need, again, research and evaluation programs to determine how effective these methods are. And when there are differences in how effective it is across groups, we need to kind of examine those more closely and see what are some of the things we can do to improve outcomes or improve the effectiveness of various assessment and treatment methods that we're utilizing in these different clinical settings. So I think that's really a huge part of it. A population health approach, looking at the whole person, looking not just at what are some of the symptoms they might be reporting, but looking at all of their functioning, their overall level of functioning and well-being and adjustment. And I think that really an integrated care delivery system under a population health a philosophy or approach, I think is probably the best way to get at that early identification, early screening, early intervention, as well as preventive measures as well. So I think that's a really important aspect to all this, but that's at a macro level.
Excellent. Thank you, Dr. Cormier. Thank you, panelists. That was exceptional in terms of the solutions conversation. Really wanting to close out this dialogue around, we've done the problem exploration, right? We've done our problem exploration, but we need to get to a space of solutions, or at least some tangible action items that we could be able to share with the audience around how we get some traction around needed areas to really cultivate equitable spaces as it relates to mental health. And I definitely appreciate how we infuse the conversation about interventions and needed interventions, whether it was interventions to address physical barriers, interventions to address kind of information sharing and ensuring that that happens in the way that it needs to, or even interventions to educate providers about how to engage the patient population. Even the population health component, Dr. Palmieri, as you were making mention of, but also the specific, target populations. How do we enhance the notion of an equitable space as it relates to mental health? So we are at the 2-minute mark. I do want to give our panelists an opportunity if there's anything additional you would like to share before we close out for this afternoon.
Dr. Jackson, before you guys go, there is a question from our YouTube audience.
Okay.
And do you see it at the bottom?
I do see it. Yeah, I can go ahead and
okay.
That. Question: how does the built and natural environment influence mental health outcomes? Again, to our panelists, how does the built and natural environment influence mental health outcomes?
I've not heard the phrase that way, so maybe it's an architect asking the question, but it sounds to me like a social determinants of health type concept that, we certainly gets back to some of what Dr. Palmieri said. If transportation is a problem, that's an issue. If there are food deserts, that's an issue. Anything that would add stress and perhaps even multi-generational type problems, to me, would be a negative outcome as far as mental health pieces. I'll see if the others have a comment for that. I do have one last comment at the very end when we're done.
I agree with what you said. I think maybe it's an example of where the system approach that I just mentioned, where there's a population health approach and healthcare organizations are reimbursed based on how well they can keep their population healthy, not just can it help them when they come in because they're not feeling well, but how to keep them healthy. And that means investing in the communities. And that could mean, anything from helping to, working with communities to build green spaces, parks, could be helping to, collaborating to make sure that there aren't food deserts or pharmacy deserts, even, in different regions and neighborhoods. So I think that this definitely needs to be a focus of healthcare in general, and certainly healthcare that's going to be considered to have achieved equity.
Thank you. And Dr. Smith, I believe you had a closing remark you wanted to share.
Sure. So, on the heels of this excellent your talk and then our discussion here, which is, a social determinants of health could be another 2-hour discussion. So we can't quite fit that in. But I wanted to really, for the viewing audience and others, just to invite you to be part of the solution. We have a countywide suicide prevention coalition. It's actually a very diverse membership. We have an even larger opiate and addiction task force that works on this and includes everybody from people currently in their own recovery, family members of those in recovery, police chiefs, judges, anybody you can name are there. And then actually Dr. Palmieri is the co-lead for our countywide trauma-informed care coalition, where I'm certain we could engage other members so that we have everybody at the table to be able to make sure we're working on the right issues and the right solutions. And those are all on the ADM board website, admboard.org. So if you go there, there's a whole list of coalitions. There's more than I named, but those are 3 big ones that we're happy to have people engage with us, and we'll try to help them engage with everybody in the system.
I think, and if I just can add to that, which I appreciate the invitation, and I guess my thought, even prior to Dr. Smith bringing that up, is in connection to what you were speaking about earlier, Dr. Jackson, which is this idea of social and community context, and really going to the community and hearing from the community and what it means to really center their voices, our voices, and to also bring out the strengths that are already there. So how do we highlight the values, the strengths, the resources, the healers that exist, right? Because we can't just do it as providers and as systems. There are natural ways that people heal and are well within their communities? How do we elevate those strategies and practices and center that in helping us to all be, in engaging with each other in a way that is healthy for individuals and for us collectively?
Thank you. All right, excellent panelists. Thank you once again. It's been a phenomenal discussion. Tamika, I'll turn it back over to you.
Thank you. Thank you to Dr. Jackson and all of the panelists. I truly enjoyed the conversation today. I want to say I echo all of your comments, your closing remarks to the community to engage in the solution, because so oftentimes government providers all think we know what you all need. And I would also encourage some of the, all of the attendees to share with your colleagues the link, the YouTube link, and to share this both days, because it was a wealth of information that I think you could share with grand rounds, with residents, with some of your different colleagues, your friends, just to see what's going on in the community and how they could be part of the solution, because we don't have all of the answers. So on that note, we'll take a 10-minute break before we get into President Somerville and Mayor Horgan to talk about what we're doing here in the city to reimagine public safety and decrease violence in our community. So we'll take a 10-minute break. And once again, thank you so much, Dr. Jackson. I truly appreciate your time today.
Thank you.
Thank you. Okay. Thanks, Jake. I got to go to the bathroom. I was holding it so like since.
Might want to mute.
Okay, thank you all for returning. We're going to close out the summit today with a talk about reducing community violence here in Akron and reimagining public safety. Today we have Carla Chapman here from the Akron Public Schools to moderate a discussion between Mayor Dan Horgan and Council President Margot Somerville. Carla, I'll turn it over to you.
Thank you, Tamika. Good afternoon, Mayor Horgan, Council President Somerville. How are you today?
Great.
Doing well, thank you. Thanks for having us on. Hi, Margot.
Hello.
Thank you for having me. I appreciate the opportunity to facilitate this conversation. So let me just start with a personal note. I cannot imagine anything more traumatic than losing a loved one to a violent act. And so that being said, as we're discussing healthcare disparities and addressing those social determinants of health, let's transition our conversation to the impact of youth violence and look at it as an area of opportunity to improve health outcomes for our community, especially in terms of physical safety, mental and behavioral health. So I'm going to start with you, Mayor Horgan. Can you tell us about your 5-point framework and why you believe it is a good plan to reduce violence in our community?
Well, good afternoon to everybody. Carla, thanks for having us on. You know, as we've talked about different things about how to reduce violence, to me, you know, we started with the Youth Violence Reduction Plan back in 2017, and there were a lot of community partners involved in that. And a lot of times, I think the discussion was always on the enforcement side. Hey, we need to do this as police. And really, that's not the answer. Certainly, public safety is one of the most important things in a city, but we also had to invest monies and invest our time back into how we do that. And coming up with a framework, you need something, I think, a plan to be able to say, because it's a whole of Akron approach. So whether it's on the prevention side, enforcement side, the partnership and advocacy, whether it be philanthropic or schools, hospitals, also community accountability, but also I don't think we've ever done intervention and support in a very good way. And in that historically, we've seen other communities do parts of this, do all of that. And there's a significant amount of peer learning going on with this too. We talked to a lot of mayors across the country about how they're trying to address, you know, the youth and community violence. I personally think, you know, I think youth employment could be a big factor into that. And I know we've had some fruitful discussions with the Akron Public Schools about how we talk to seniors and then kind of go from there. But it even backs up into that middle school. And I don't know whether as a city we've been as engaged as we should have been in middle schools and in high schools to be able to, you know, put a different a plan forward to be able to reduce youth and community violence. The availability of firearms, you know, the first inclination to solve a dispute with a firearm. Those are all, not that they're new, but they're a lot, they've been exacerbated over the last 18 months. And so putting together this framework, and now I think, which was one of the most important things, we have a significant amount of funding to be able to put behind it. And I think that's the most important thing. We as a city have always talked about, you know, our fiscal position wasn't that great. We had to, you know, raise an income tax, you know, a few years back to do some things. I think now we have some real resources to be able to put behind prevention, intervention and support, enforcement, partnership. To me, that goes a long way into, I think, building better community trust and making better inroads into the community to be able to reduce violence.
Thank you. Want to go back a moment to the prevention component of the framework and get your thinking about how you see that taking place in collaboration with our community.
I'll take the one example, and I'll take Akron Public Schools because we've been significant partners over a number of decades. One of my goals, and Tamika's going to kick me when I say this, is that I would like to give the opportunity for every high school senior in the city of Akron and Akron Public Schools an opportunity to work for the city. Both President Somerville and City Council, we've talked about this for a while, about how we set up a framework to do that. They don't necessarily have to work there, But as our workforce ages and we try to recruit people to have a more diverse and culturally competent workforce, we need to replace a lot of people. Why not work for the city? And I think giving them that opportunity in a real job too, not it's not $8 an hour. It's not $7.50 an hour. It would be significant. Of course, it's not full time, but I think opening up the city as really a world-class internship program for Akron Public School students, I think that can go a long way to the prevention side. There's a lot more to it, but it's one thing that I think we can put a significant amount of resources in, and I think it would go a long way to being able to help on the prevention side.
Thank you. This was a perfect segue actually to another thought I was having. We've unpacked social determinants of health and wellness over the past 2 days, and economic stability is one of those. And so when you talk about the connection between workforce development, young people having the opportunity to earn money, what do you see as that connection between poverty and the rise in gun violence in our community?
Well, we started a war on poverty in 1965, and 55 years later, we still haven't won it. And now we're starting to talk about, over the last 10 years, generational poverty passed down from family to kids. To me, that's a failure as a society, that we haven't said, especially in communities of color, where we said, you know what, we haven't started everybody out equally. And that goes back, that's a systemic problem that has existed for a long time. Our thought is, we have to break cycles of poverty. So when you say you take a high school senior and they start to earn a little bit of money, those are important decisions that they have to make at some particular point. And I think understanding that, hey, this is a better path for me, or this is a path, I think opening up those opportunities to economic stability, because quite frankly, working for the city is a pretty good job. We're fairly stable. We don't lay off a whole lot. The benefits are pretty good. I think there's a lot of opportunity there, and it opens up a lot of other opportunities. I just don't think we've been open enough to be able to do that. Now I think we have the resources to be able to help break some of those cycles of poverty, to be able to do it. It's not by ourselves, and it's not alone. I think it is with a lot of community partners, and putting together a framework and really having the capacity to be able to do it.
Thank you. Council President Somerville, I see you kind of shaking your head, moving around. Anything to add to that?
I think, Mayor has really said it all, but we definitely have an issue, when it's easier for people to get a gun than it is for them to get a job. And so that's a serious problem. And I don't know who said it, but I like the quote was, nothing stops a bullet like a job, right? Yeah. And so that's just really deep. And so I think, we have a responsibility to create economic opportunities. We have to make sure that, people in our community have access to job training, educational programs. So those things are really, really, really important. And it's going to help us as we move closer to reducing gun violence in our city.
Yeah, we often talk about the debilitating effects of experiencing poverty and how chronic and intergenerational it can be, affecting so many things, and that additional stress, right, associated with survival. We know is part of what many of our young people and families experience if they're living below the poverty level. And so thank you for that conversation around that. President Somerville, talk to me about the City Council's Reimagining Public Safety Plan.
Yes, thank you so much. So in July of 2020, Akron City Council, we announced that we were going to be forming a special committee on reimagining public safety. It was our effort to create a process by which City Council could participate on ongoing conversations around policing and public safety. So we recognize that in order for us to make sure that there is continued trust between law enforcement and the community, it requires us to constantly improve our systems. That's how we recruit, how we train, use of force, technology and accountability, and so much more. And so what we wanted to do was we wanted to do a deep dive. We wanted to have a dialogue with our Akron Police Department and ask questions about, what is it that we do well, but also where are the areas in which we can improve. And so City Council collectively came together, did an amazing job, and brought forth some really amazing recommendations that can really bring forth meaningful change to make our community safer. Some of those recommendations included just community policing, right? We've got to create more opportunities where people can interact with police outside of emergency situations, right? That's going to help us bridge the gap between, police and community. Another recommendation that was brought forth in the report was just really making sure that all of our police officers, patrol officers, and administrators had crisis intervention training. We know that mental health and crisis issues can be some of the most difficult, dangerous and complex calls that, police officers go on. We want to make sure that our police officers are equipped with the training so that they can best respond to residents in these situations. And one of the great things that we found out when we were doing this reimagining public safety, our police officers are doing an amazing job, particularly in this area, making sure that all of our officers have the necessary training that they need. So when they get out on the streets, they can respond to these situations in the best ways. The last one that I wanted to share, recommendation, and again, these are conversations that hopefully we'll continue to have. I know that Mayor Horgan is also in favor of this, is the whole idea of how we can include social service professionals on 911 calls, right? Oftentimes, our police officers are sent on calls that are maybe best handled with a social worker, right? Which would allow our police officers to spend more time, fighting crime and focusing on more serious calls, right? So again, these are just some of the recommendations that will help lead us in the direction of making Akron safer, but also a more fair and just community as well.
Yeah. How do you make that happen? Either one of you could contribute to this. What does that look like, social service professionals teaming with our police department?
I'll defer to Mayor Horgan because I know this is something that he's looking at along with our police leadership.
Yeah, we've seen this model in other cities across the country where, to me, and I'm not the mental health expert, but especially we've seen a working model with our QRTs, those quick response teams, into responding to opiate overdoses. We tried to drive down the number of emergency room visits, but a QRT visits somebody with a medic, a police officer, and somebody who is in addiction services to get somebody into a bed. To me, I'd like to model it something of that. We have talked about two big things. One, and these are aspirational, but I think they're very doable on this. One is that I think we should probably we should talk about embedding clinicians in dispatch to look at what type of call comes in and how it gets classified as a mental health call. And quite frankly, I think we probably need a 24-hour crisis response person or team that is able to respond to those mental health calls. And it really is about that call into dispatch that says, however they're going to classify that in the language that they use, somebody that's going to go on a mental health call. And I applaud many police departments across the country, including Akron's, that has done a significant amount of CIT training. It's also ongoing when it comes to that. You need to kind of keep going and do continuous training, I think, on that crisis intervention. But having somebody, I think, trained in that way on the crisis intervention go out, I think would be extremely helpful. And I think they should be embedded, or there should be a response team that responds together, because it is about it is about the safety of the people making the call, maybe the people in the home, our officers and the clinician. I think we can respond and do that in a pretty effective way to maybe reduce the risk for everybody involved. And so those are two of the things that I know we're talking about. with a lot of organizations to be able to help out with. And so I think that would be a great step forward for the community, for the police department, and in mental health.
Mhm. Thank you. One other thing I heard from President Somerville is the idea of returning to community policing. And I know that we've had a community policing model in Akron prior. What could look different?
I think a couple of things that play into that is that, especially with the numbers of where we are, obviously and everybody is in community policing. They've been trained that way, but having a specific unit that does those things, they've kind of rebranded it to neighborhood response teams. To me, it goes back to the mentality of, because I think sometimes it says on the side of the car, to protect and to serve. We can flip that too and say we can serve and protect. And I think that's the model. And Chief Chucker in the fire department told me one time is that when somebody goes on a police and fire call, it is absolutely the most stressful, most impactful, high anxiety time that you will ever see a person. Having somebody respond in a way that is empathetic to those while still trying to protect everybody, I think is key on, like Margot said, how we recruit, how we train people into interacting with the community. And I think that's an excellent training opportunity, not only for our department, but also for the community to say, these are the things that, these are the things that they're going to be asking. This is kind of the process that they go through. And every positive interaction, which I know there are a significant number, that creates better community trust. And I think that's the key in all of this.
Absolutely. Speaking of the trust, President Somerville, there was a section of the Reimagining Public Safety recommendations that included accountability and transparency to the end of really ensuring more community trust. Can you talk to us about that?
Yeah, absolutely. I think the biggest component in the accountability and transparency recommendation really dealt with the police auditor. And in the recommendation, we really wanted to make sure that the police auditor had sufficient authority to access information, wanted to make sure that the position had adequate staffing, also wanted to make sure that funding was there as well, and also independence in the process. All that was really important to City Council. The good thing about it is, with the help of Mayor Horrigan, I know also our social justice task force did a lot of work as it relates to our police auditor. And so there were some issues there at first, right? It was difficult for the police auditor to access information. He was like a one-man show. And so we were able to make some adjustments, right? We were able to get him a paid full-time administrative assistant. We were able to move his hours to 40 hours a week. We were able to make sure that he had the necessary access to information so that he could do the job. And so I think that's really important. But again, that's how we do this work, having these conversations, working with the mayor, working with the administration, working with the police department. That's how we make real change and make steps towards to really being accountable and transparent. And again, this is just the first step. Again, we got to do a lot more work as it relates to the police auditor, but I think we're moving in the right direction.
Mm-hmm. Mayor Horrigan, anything to add there?
Yeah, and it's important to note that I think Akron was probably one of the first communities in Ohio to have an auditor or an oversight in that respect. And certainly the job and the process evolved over a certain amount of time. And I think specifically probably in the last 4 or 5 years, that job has evolved into something else, which means changing the process, which means, more accountability and more transparency and a closer working relationship on how that works, because ultimately, we are responsible to the community. And at some particular point, they're going to say, hey, listen, we don't think you're being accountable or transparent, and this would be the result. And so as we continue to work through those processes, that'll be part of it about, that independence and that I know as elected officials, we have people looking over our shoulder all day, and I have no problem with it because that's what we signed up for. It is the same thing on that, is how are we transparent to the community? Being non-transparent just does not build trust. And so that's, like I said, that's a key thing on a daily basis that we're trying to continue to build, is trust, specifically in communities that don't trust us. And to me, that's the most important part.
Yeah. And I just want to add, if I can, and again, with the help of Mayor Horgan, City Council, we put a charter amendment on the ballot in November of 2020. Akron residents voted for it overwhelmingly. And that was to be able to release body cam footage when, there's deadly use of force. So again, we want to be accountable. We want to be transparent. And so again, that's another step in that direction where you see Akron leading in that area of accountability and transparency.
Yeah, I was going to mention that. I just tagged it here in my notes. So thank you for bringing that up. So we have a couple of things going on. We've got the 5-point framework for addressing community violence, and we have the Reimagining Public Safety Plan and recommendations on enactment by City Council. So how does the average resident, the average Akron resident, know that these things are working? How do we move it from what's on paper to actionable plan to work within our city government?
I'll take the first part of that. And I think it goes back to, putting together a framework to begin with. Also, there's got to be some sort of metric and kind of a judge of saying, okay, this is where we started and this is where we want to end up. Obviously, I'd love the number of, use of guns to go to zero. Just like infant mortality, it is a lot about holding ourselves accountable and reporting to the community. And we plan on doing that, in a very public way to say, these were the recommendations from the Racial Equity and Social Justice Task Force. How do they marry up with City Council's Reimagining Public Safety? And in that framework, who is accountable, who's doing intervention? And as we put those resources towards certain action plans, it's starting to measure ourselves to see if it works or not. And then at some particular point, you're going to have to grade yourself and change course if it's not working. And I think one of your questions had asked, what's different? That's a good question, because I read a plan from 1996 that told me the same damn thing. Excuse my French. It did. It said there's a high availability of guns. It's disproportionately in the African-American community. And here's what we should do. I don't want to just do the same thing and hope to get somewhere else. Just because we have resources to be able to do it, we all have to hold ourselves accountable to say, hey, listen, this is where we're going to be. And if we need to change course, or if we need to have a different, an action plan, I never want to sit on something or say, hey, listen, all the best ideas are just starting the mayor's office. We do a significant amount of research to be able to say, what are other communities doing that are being successful? That is a successful economic opportunity, educational opportunity, investing in neighborhoods where we haven't invested in a long time. That's what we plan on doing in a significant way with the American Rescue Plan dollars, because it's called rescue for a reason. And I think we need to implement those, especially in communities that we have not been able to invest in or haven't in at least 25 years, if not longer.
Thank you. President Somerville? Anything else?
The mayor has said it all, but just a couple of things here. We as elected officials, we don't have all the answers, right? And so we do need to hear from the community. And I think we have a great opportunity ahead of us when we're talking about our American Rescue dollars. And we've got an online portal right now where residents, nonprofits can go and they can submit their ideas. They can submit their proposals in terms of how they can help us and work with us to make our community safer and to reduce gun violence. And so again, we need to create more opportunities just to engage the public and get feedback from them. And the American Rescue Dollar process has done that for us. And so just want to encourage anyone who's watching to, you've got an idea, you've got a program that you think can help us as we try to solve gun violence in our city. That online portal is there. We need to hear from you, and we need to hear your ideas.
Is that on the City of Akron's website?
It is.
And I would just add one thing is that, the how, a lot of that guidance is being determined obviously by the federal government, because they can tell you, hey, you're going to be able to spend these dollars this way. The where, and listen, is everybody's idea going to be accepted? Probably not. But that's one of the things that I think make this a transparent part is that, we want to see ideas that maybe we haven't thought of before. Because maybe, like I said a little bit earlier, I don't want to sit there and judge myself and just do the same thing and expect a different result, because that's not fair to the community. It's not fair to everybody else.
Right. I agree. One of the things we talk about in education is the impact of exposure to community violence on students and their behaviors in school and their ability to learn, and the anxiety, aggression, depression, inattention that they bring with them to school as a result of the violence that is taking place. How can we do better in maximizing use of our community learning centers as safe spaces during those non-academic, non-school hours to address community violence?
Well, I think we need, and we've had some initial discussions about, what does out of school time look like? I mean, if school and community learning centers are those safe spaces, number one, I think we have to reduce some stigmatism around mental health and talking to people about how that may help, but also better utilizing those community learning centers, because that's a significant investment in every neighborhood. And I think it's to the tune between $350 and $400 million that we partnered on to be able to build all of those schools. Those need to become more active. And I know there's a lot of programming that runs through there. But if we can kind of define what out of school time, and for some kids, it's going to be a sport. Some kids, it might be reading. Some kids, it might be culture. It's really, they're the market. And I think the kids have to tell us, listen, we'd really like to see something like this, or we'd really like to see something like that. We as a community, with the Akron Public Schools in the city of Akron, along with our community centers, we need to be able to provide that programming too. Really, the last 18 months have been kind of difficult just around COVID, but that doesn't mean we can't emerge and I think find that opportunity to be even better in those community learning centers and our community centers for kids out of school time.
Anything else to add there?
Yeah, I mean, definitely. Gun violence creates trauma for individuals who, is impacted by that in those communities. And so, I would like to see us use our community centers for community healing, because our community needs that. Not only does our community need healing, but we also need to know how to deal with our grief, right? And how we can use our community centers to have more conversation and helping our young people deal with grief. Oftentimes we deal with grief, we go to the location of the crime scene and we put up the teddy bears and we light the candles, right? But we never really deal with the emotions and all the things that come along with that. I think I would also like to see us keeping our community learning centers and our community centers open as late into the hours of the evening as we can, right? Just creating safe places for our young people to play a sport or just to hang out and be safe.
Absolutely. So I'm going to challenge the both of you to think about your best advice, your message of hope to a young person living within the city of Akron today, thinking about their future and what's ahead of them in terms of their health and well-being. What would you say?
Well, Carly, you ended it with a tough question, but I've spent a lot of time before COVID talking to seniors in the Akron Public Schools. And the hardest question that I think that they will ever get, and they will go on to maybe be doctors and engineers and lawyers and take a lot of hard tests. I ask them specifically, tell me what you want. How can I help you? And I think that's one of those questions. So if I'm going to challenge them, or if I'm going to ask them a question, what do you want? And they're, quite frankly, they're pretty frank and honest about what they want. Some of them do want to move away and they just do. And my job is to convince them to stay, but we got to give them a reason to. And so as we take all of that, investing in that public space when it comes to the community centers, giving them a better educational or economic opportunity, but also giving them a message of hope that people that sit in our offices as elected officials, we do give a damn. We do care about their plight. How can they help us though? They've got to tell us what they want. They are doing that, I think, in a big way. But it does involve, I think, even a better line of communication between kids in the younger generation and us who sit in these offices.
Thank you.
That's good. I just kind of want to echo a little bit of what Mayor Horgan says, is that, we want young people to know that, first off, we care, we hear them. And we want to be able to make sure, particularly as a mother, I have children, I want to make sure that, the city of Akron is a safe place, for my children. And so we got a lot of work to do, but I do have hope. I'm encouraged. I think that we're in a unique opportunity as we begin to figure out how we're going to invest these dollars so that we can make sure that we do have a safe future for our young people.
Thank you. And we knew that there would likely be some questions possibly in the Q&A for the two of you. So I'm going to ask Tamika if you'd like to open it up for questions from the audience at this time. And if the mayor and council president are open to that, we can kind of filter those right now.
Sure.
Thank you. Thank you, Carla. Our multimedia specialist is checking the YouTube audience, and we have one comment in the chat from Dr. Smith.
It says there is a demographic of citizens not connected to Facebook, Twitter, Instagram, and electronic media sites. Has there been conversation about reaching citizens not electronically connected to resources? So how do we connect with those who are challenged that way?
We talk about this weekly, is how do we communicate better? And when I talk to a younger audience, they all have those phones. And if I wanted to get a message to them, I've got to do it that way. They're not read the paper. They don't necessarily listen to the radio. So there are multiple channels of how we do that. And quite frankly, sometimes maybe we don't take advantage of some of those channels as best we could, whether they be in water bills, in flyers. Sometimes it's just, it's an old fashioned way of communicating, whether it's a phone call or whether it's something in print media. But it's always been, I'm not saying, I think we do a pretty good job, but there's still an audience that we don't reach enough. And quite frankly, that's going to take some further discussion about how we do that, because if they're not engaged in social media and if they don't want to be, I don't want to say they don't want to be bothered, but if they don't want to be communicated with, it's hard on that end too. And it's not perfect. But we try and use as many channels as we can, both print and electronic, to be able to get some of those messages out, but it's not perfect by any stretch of the imagination.
It is tough. And I will also put out here too, council members hold monthly ward meetings, right? Once a month. And those are always just really, really, really helpful. A way for citizens just to be engaged and know what's happening in and around their community. So we do use that time as a great way to pump information out, because it is tough. Even though we have so many forms of ways in which we communicate, it's always hard still to get the information out.
I agree. You're getting kudos from a person on YouTube who is thanking you for the improvements and the great ideas, and continuing down that line. How do we increase treatment options to mental health patients who are not sitting in emergency rooms and who are not sitting in emergency rooms for extended periods of time and emergency departments? How do we get some relief to people who have mental health challenges?
Before the mayor or President Somerville answers, we actually still have Dr. Smith and Dr. Palmieri on the line. So if you guys want to help our elected officials here answer that very detailed question, I would appreciate it if one of you could help them answer that question. Dr. Smith, are you still there? Okay.
Sorry, I'm actually multitasking. So is this the not sitting in an emergency room question?
Yes.
Yeah, well, so great question. I think this is actually partly a COVID issue, and we certainly had times pre-COVID in the system where we would find that psychiatric emergency services in the ADM Crisis Center, the Cleveland Clinic Akron General ERs, and the SUMA ERs were all full. And of course, what they have to do is triage, which means if you go in with literally not having a heart attack, not having a kidney stone, it may take time to be seen. So I agree. I think this gets back to probably different staffing models, which is not my area of expertise by any means, for the emergency departments. So to feel that there's some kind of relief probably would take a grand plan looking at I know the hospitals do their service plans every year. I forget the name of those, but the plans, maybe in those plans, given this discussion, we can have that input. That may be an example of where we don't have enough, if you will, consumer patient input. So the hospitals do their plans, and ADM does our plans, and others do their plans. If we don't have enough input from people, like, this is what really bugs me. I know that in other parts of the country, they'll even basically compete on time in the ERs. We're not one of those areas. Ohio's not one where they'll actually post. They've literally got big billboards up there, electronic, to tell you what the wait time is at every ER. So you can decide, oh, I want to go to that ER. And they try to keep themselves at 10 minutes or less. That is a true issue. And I know in Tennessee, for example, where I had some exposure. So just, I don't know the full answer. I apologize, but I think from it's probably a grand planning thing. And of course, nobody alive was ever part of planning the first pandemic back in 1917. So we've all been learning as we go here. And I think they tried. SUMA, I remember seeing pictures of the big tents outside, to add beds. I don't think they ever needed those for COVID, which is, thankfully we didn't need those, but I think there's big issues there that probably need a voice from actual people going to ERs and saying, why am I sitting here so long? You're muted.
You're muted, Carla.
Well, how I deserve the t-shirt. There it is. What is the Summit County Juvenile Court's involvement in issues regarding gun violence? Would you like to comment on that, Mayor Horgan or Council President Somerville? Are they involved in any way?
Yes, they are, and they're a key partner. I think as we look at that framework, a part of it to me is also on the accountability side too. Is that, and I'm certainly I'm of the notion that we can give people second chances. It's certainly but there's got to be some sort of a programmatic model that says, okay, if you're going to be involved in gun violence, you're going to have a gun. There's going to be consequences at some particular point, but further working or collaborating with the court is certainly our goal. And they have been a partner on the youth violence reduction plan on that. It to me, it takes it a little bit more on the integration side as we roll out stuff around prevention and intervention that involves them even more.
As we think about the involvement of a juvenile court, it reminds me also that we do the work of connecting with our school resource officers in schools as well. And I know that is often the first contact that young people have with criminal justice or a police officer. What are your thoughts about how we can better the relations between SROs and students in schools?
Well, I know I know they go through a pretty rigorous process to do that to begin with. That is their first interaction, and making sure that is more positive than not as we do that. I think it's even as you look at the people that are involved in being able to do it, it's kind of a two-way street, how they interact with each other to be able to do that. I know we've worked fairly close in those SROs and positioning them and having them in the schools to make sure that schools are safe, because you've seen events around the country where people don't have SROs. And so I think they're a key component on that first interaction, but it's also finding the right people to be able to do that too.
Yes, thank you. There is a question concerning how viewers could learn more or get information about ARPA funds and the improvements in community centers. And I'm assuming these are City of Akron community recreation centers.
Yeah, we have detailed some of those as we went back through, even back in March and looked at the guidance that said, hey, this is how you can spend the money. I know we had some detailed conversations with council leadership. We did a community center study probably about 3-4 years ago and identified which ones are the worst, and have identified from there and said, okay, we also knew that public space is important, especially for the community. They need to, in public space is different than it was maybe when I was growing up. We went to a park and we generally played a sport. But those community centers now involve a lot more programming. So we have some detailed plans, I think, to upgrade 3 of the community centers that need it the most. We were going to do it through the capital budget anyway. This just gives us an expanded schedule or a quicker schedule to be able to make improvements into Ed Davis, Patterson Park, and Reservoir, into those community centers and pools. We heard overwhelmingly that the pools are extremely popular as a summertime activity. To me, that's going to be a big investment into those neighborhoods, along with the CLCs that are there.
Thank you. We talked some about the importance of young people having workforce development skills and being more prepared to move into the working world. How can our community partners help us in building those skills for youth in age group 16 to 24 years of age? What else do you think they need to become adults in our community? And then how are we able to look at the gaps in what students or young people need?
Workforce has always been one of those ones that it never really seemed like, maybe in the previous 50, 60 years, it really never seemed like, and somebody owned it. They woke up every day and said, okay, this is what we need. This is how many tire workers I need. We kind of relied on, the schools are going to give us a certain number of graduates, a certain number are going to go into the military, a certain number go to college, a certain number get a job. Especially with the younger generation today, I think their expectations of what comes next is a little bit different. And it's really the skills and kind of, I think we have to assess the market better about what kids want. What kind of jobs do they want? I think on our end, I think we can expose them to some of the great organizations that employ a significant number of people, like the SUMAs and Cleveland Clinic, Akron General, and Akron Children's Hospital. That's healthcare. That's a significant, which is why we have the Healthcare Academy at North High School, and why we have those college or career academies. I think the exposure on that end has done wonders on that. But I think we have to even go another level deeper to say, okay, what's the next level? What's the next reiteration of what workforce development is? And that's a changing model of education about what skills they need to come out of there. I'm certainly, I think there's a pretty strong partnership with that going forward. But it's also, is there an organization that owns it on a daily basis? Because companies tell us, hey, I need 20 people. I need 15 people to do this. And right now, I can hear from every company around the country, around the area, they're struggling to find people, and they're paying more. That's kind of oxymoronic. They've raised wages, increased benefits. We'll do a signing bonus, and people still aren't going to work. I mean, it takes a little bit. I think you have to go another dive about what the needs are and what the market actually wants from a workforce development side.
Yeah. And Carl, if I can just chime in just for on one point there. One of the other recommendations in City Council's reimagining public safety was actually a pathway to policing, right? Just making sure that, we can ensure for a diverse police force in the future, more police officers that look like me, and getting young people hooked up in internships so that when they reach the age that they're able to take the test, oftentimes what happens is that, they've done something at the age of 15 that's on their record that will never allow them to be a police officer, right? So Pathway to Policing is about giving young people internships, keeping them occupied, grooming them with mentorship. So when they get to the point where they can sit for their test to become a police officer or any form of public safety, they're ready and they're prepared. So again, these are just some of the things and the ideas that we're thinking about.
Mm-hmm. And we talk a lot between the two systems, government and education, about the qualities of a graduate beyond being workforce ready and academically ready. We want our young people to be strategic thinkers, to be able to receive feedback, to communicate well, work well with others, have a creative genius about them. And so all of those things are important as well, regardless of the type of field or profession they might want to go into. It's the soft skills that we want them to have as much as the other areas of proficiency we look for as well. I think we've come to the end of our question and answer session. And so I thank the both of you for being open and honest and willing to have a conversation today, to take the questions that you may have been more prepared for and those that you weren't necessarily, but handled just as well. Tamika, I'm gonna send it back to you.
Thank you, Carla. Thank you, President Somerville and Mayor Horgan, for participating in the Health Equity Summit this year. Truly appreciate it. And to the audience, I hope you all learned something over the past 2 days, and I hope you connected the dots of racism, inequity, and behavioral, physical, and mental health. One of the common denominators in all of this is social determinants of health, and we know that the root cause of that is racism. I leave you with to think about how you can move towards a more equitable lifestyle in your place of employment and in your personal life. And we look forward to hearing more about your ideas as we prepare for our next Health Equity Summit in 2022. And we look forward to seeing you in person next year. I wanted to say thank you once again. I hope you all enjoy and honor our veterans tomorrow. Thank you for your time, and we look forward to seeing you next year. Bye.
Thank you.
Thanks, everybody. Thanks, Carla.
Thank you. Goodbye.